inaugural meeting of the Health Insurance Marketplace Advisory Committee. My name is Pat Allen. I'm the Director of the Department of Consumer and Business Services, and until you all elect a chair, I'll go ahead and facilitate things as we get started. It's a little bit hard to believe that we're actually just more than a year from the passage of Senate Bill 1 and the statutory creation of this group. It took us a little bit of time to get appointments and all those things squared away, but we're really delighted that you're here. It's also kind of overwhelming to realize that we're about a year and a half away from somebody in some dark room in the Capitol saying, hey, I know, let's have DCBS take over this stuff. And it's been a pretty wild ride for that period of time. I thought what we would do is start out by doing a bit of self-introduction around the table, and maybe if more than just sort of name, rank, and serial number, in addition to name, rank, and serial number, give a 15 seconds or so of what your interest is, what draws you to be interested in wanting to do this, and a little bit about why you're here. Jesse, you want to start?
Sure. Hi, everyone. I'm Jesse O'Brien. I'm the Policy Director of OSPIRG, which stands for the Oregon State Public Interest Research Group. It's a statewide consumer advocacy group. And my organization has been involved with the Oregon Health Insurance Exchange since it was in its infancy, before any legislation was even really being conceived, although that was before my time. We think that the marketplace is a really critical tool for making healthcare work better for consumers. So we want to be involved with every aspect of it that affects the consumer experience of purchasing health insurance and using healthcare. And we think it's a tool that could really make healthcare work better for Oregonians. And we have our work cut out for us to make that happen. But I'm very enthusiastic about participating in this, and glad to see you all here.
Thank you.
So my name is Jim Hauser, and my wife and I own Hawthorne Auto Clinic for 33 years. We have 14 employees. It's a fairly high-tech industry, working on a lot of late model cars, and therefore we go to great lengths to find the best employees and to keep them, which has meant, among other things, providing full medical coverage for our staff and their dependents, which was fine when we started 30 years ago. It's gotten extremely expensive, and like from 01 to 09, 180% increase, something like that. And so in 2008, 2009, during that presidential election, a small business organization was surveying door to door, looking for volunteers to become involved in healthcare reform. Both candidates in 08 were talking about healthcare reform. And I volunteered because there was no way for us to continue to offer the healthcare without doing something crazy. So I had the opportunity to go to Washington, D.C. and testify, speak to our congressional delegation. I had Senator Merkley and Representative Blumenauer at our shop to speak to small business owners. I also had the opportunity to become involved in what became Cover Oregon, and then I was on the advisory for Small Business and Consumer Advisory for Cover Oregon. So I felt like I have invested enough time and energy that I had something to offer, that I learned enough, I think, to be helpful in moving this forward when I saw an opportunity to apply for the board. And I thank you very much for accepting me, and I hope I can do a good job.
And thanks for pointing out that increases in rates happened before the Affordable Care Act as well, which
so let me tell you,
seem to forget about occasionally.
I've got the charts at home. It's leveled off. It went down 3% 2 years. Last year it went up 10%. This year it went down 13%. And I can show you the spreadsheets of it. So it enabled us, for example, to expand. We have student interns, and we were able to promote 2 student interns to full-time based in part on the fact that healthcare had leveled off. It was an expense. There's always increases in expenses, but it was one of the most dramatic ones in the past that with the leveling off gave us the confidence that we could expand our employee base. Yeah, it made a big difference.
Joe. Good afternoon, everyone. I'm Joe Finkbonner. I'm the Executive Director of the Northwest Portland Area Indian Health Board, which is an organization that's owned and operated by the 43 federally recognized tribes in Idaho, Oregon, and Washington. Before I went to work in Indian Health, my previous life was a hospital pharmacist. I worked in Seattle area, in Bellevue. Also did some home health care and health information systems for a small IS company that got gobbled up by a larger hospital information system by the name of FAMOS, Public Health Automated Medical Information Systems, which was built for the public health hospitals throughout the U.S. and for the Merchant Marines. So I've always had an interest in healthcare, and my interest on being on this advisory board is to make sure that when it's developed, that it allows for full access for all of Oregonians, but particularly access for our tribal populations that have unique provisions within the Affordable Care Act.
Well, hi, I'm Mark Fairbanks. I'm the Chief Financial Officer for the Oregon Health Authority, responsible for fiscal and operations for the agency. I've been in that chair since almost a year, since late May. And I spent a lot of time in Central Oregon. I was working for the St. Charles Health System, responsible for the St. Charles Medical Group and the notion of integrated delivery design. And so before that, I was with United Health. And to keep going, I done a lot of different things. So really great to be on this committee. It's very timely, not only for my work every day with the Oregon Health Authority and its expansive portfolio and body of work, but also I serve currently as the vice chair for the PEB, for the Public Employee Benefit Board. So there's a lot of interesting conversation I look forward to.
Good afternoon, everyone. It's a pleasure to see everybody's faces. My name is Shauna Butler. I am with Tomlin Benefit Planning. We're in Eugene, Oregon. We serve mostly Lane County. And I'm here because I get it straight from the horse's mouth, to use a phrase. And people, I've seen what the effects of the Affordable Care Act has done, both positive and negative, and I just want to share that. I want to share what people are saying about it out there.
Barry Leslie, I'm the Marketplace Administrator, and with the team of folks from the Marketplace, manage the program.
My name's Cindy Condon, Cynthia. My mom's the only one that calls me that. And I'm, by Shauna's description, the horse's mouth. Because I'm a consumer that has enrolled through the Marketplace, have real questions about concerns, I should say, about how the Marketplace presents itself as a consumer. I find it today, a lot of information is out there, but not the relevant information I need to make an informed decision, and it's very frustrating for me. And so I saw this as a real opportunity to get involved and kind of understand why some information is there and some information is not. And I'm at an age that Medicare will be here sooner than later. I'm really here for my children. I believe that with the Affordable Care Act, what that has brought to small business is certainly an opportunity to continue to provide health insurance if you can, but as the pressures for small business heighten with sick leave, minimum wage, whatever is challenging for small businesses, there will be a move to employees referred to the individual marketplace, and they'll be for the first time on their own finding insurance. And so for me, it's critical that the Marketplace have the information that people need to make informed decisions, and more.
Hi everyone, my name is Joe Enlett and I am with the COPA Alliance National Network. I've worked closely with this team here at DCBS and continue to work closely with them with the creation of the COPA Premium Assistance Program. which just passed and got signed, HB 4071. I come from the islands of Micronesia and immigrated over here. I've worked in the Immigrant and Refugee Community Organization in Portland, Oregon. There I was a community health worker, and I actually was one of the very first application assisters that got certified through Cover Oregon. So I have that experience really working within the communities and with the consumers. I myself have been a consumer, and my family members continue to be consumers. And so I bring that perspective as well. I really am here for community. I've been a community organizer and advocate for most of my life. And my day job, I work as a health policy analyst with the Multnomah County Health Department.
I'm Victor Garcia. I'm with the Health Insurance Marketplace, along with Barry. Handle mostly logistics, operation support, and getting the materials to everyone here on the committee. As we take the show on the road, I'll also be trying to make sure we can broadcast that to the public that might be interested in listening in.
You will all come to know Victor very, very well.
Remember Victor's name.
My name is Shannon Saldivar, and I'm an insurance agent at Revelcoin Insurance in the Dalles. I've been involved with the Affordable Care Act since its implementation in 2014. I help with Oregon Health Plan and QHPs, and I am really passionate about it. I really get to see, like Shauna, firsthand the impact that it has on our consumers' lives, and so I wanted to be a part of helping that be more beneficial for the consumers and hopefully bring my customers' experience in a voice that can make some changes to how things are done.
Hey, I'm Dan Field, Kaiser Permanente. Glad to be here. I guess I'm one of the insurance carrier representatives technically from the industry. Ken Preventure from Pacific Source is also, you'll probably announce in a minute, he's on our committee, but he's not here today, so Ken and I sort of bring that perspective. At Kaiser, I do a lot of our community benefit work, which is, as a nonprofit, we give a lot of money back to the community, both in terms of free care, subsidized care, and grants, donations, other sorts of things. So we do a lot of that. I also do the government relations, so I'm pretty tuned in to what legislators are thinking, or in some cases not thinking, as the case may be. So I can hopefully bring that perspective as well. And the other thing about Kaiser, which is true, I think, of some other organizations as well, but we're involved in every segment of the market. So we're doing Medicaid, we got a special charitable coverage program that many of you may not know about for folks who don't qualify for any other coverage, and have that. We do public employees. Mark certainly is familiar with Kaiser. We're big in PEB and OEB. So I hope to bring sort of that global perspective from our engagement in all those different programs, because I know one of the things that we're going to talk about in the coming months is how does the marketplace and what we're doing fit with the other coverage options. We're not out here on an island on our own. We're actually in an environment that has massive Medicaid program, a massive public employees program, hopefully a vibrant commercial market. That's certainly our intent, off exchange and on exchange. And of course, we have people who are uninsured still in Oregon, and I think we need to always keep them in mind and make sure that what we're doing is, to the extent we have control over that we're benefiting the remaining uninsured as well. That's something that I think about a lot. So I'm really excited to be here and part of this group. As we're going around, I'm thinking, man, there's a lot of talent around this table. So kudos to Pat and Barry for putting this group together.
Good afternoon. I'm Maria Vargas. I'm the Communications and Outreach Manager for Valley Family Healthcare. We're a federally qualified health center and also a HRSA grantee to provide health coverage assistance. I've been a part of enrolling into the marketplace since the very beginning, so a lot of experiences in both Oregon and Idaho. I've learned a lot about the process, especially in Malheur County, where the very high poverty level in Malheur County, and not a lot of resources, but it's a very resourceful community and special and unique circumstances there. So I hope to provide that feedback and also be able to share information with my community partners there, and I'm very excited to be here.
Hi, I'm Laura Lawson. I live on the very beautiful southern coast in Curry County. I have been a Chief Nursing Officer for Curry Health Network since 2011. I began my management and nursing career in 2009, but I've been a nurse for 17 years. So I'm hoping to bring that clinical perspective to the input that we have here on the insurance side, which is a lot of things that I need to learn, and I'm looking forward to that piece.
My name is Sean McNulty. I work for Project Access Now, which is the largest community partner enrollment organization in the Tri-County area, at least. And so I provide the perspective of someone who sits on the phone with clients and gets the password reset and gets them signed up and all that process, and be able to provide some of the perspective both from the nonprofit service providers and also the enrollment agents who do this for the marketplace.
Thank you. And on the phone, Claire, I believe you're there, right?
Hi, I am here. Can you hear me?
We can.
Great. So I am Claire Trancaise. I work for the Oregon Primary Care Association. I'm our training and development manager. And we're the association for all of the federally qualified health centers around the state. Hi, Maria.
Hello.
And I have worked since the ACA rolled out with all of the outreach and enrollment staff all over the state and helping train them in many of the soft skills that they need to help work with clients. And I'm just try to stay tuned into what's going on and hope to be able to share those experiences with this advisory committee. Thanks.
Very good. Well, can you hear us all right?
I can hear you wonderfully for a webinar, so thanks.
Perfect, thanks. And we'll try to do a good job of making sure to check in with you periodically, but if at any point you want to orient on the conference, just send up a verbal flare and we'll get you in.
Thank you.
So thank you all for being here. As Dan indicated, the one person that we're missing, Ken Preventure, is not able to be here because of a prior commitment, but other than that, everyone's here, and we appreciate the commitment. Barry and I and the entire team, as well as the governor, appreciate your willingness to do this and the wide array of perspectives that you bring. This is an advisory committee, and I should probably take just a quick minute and sort of talk about the nature of an advisory committee, and this committee in particular, particularly given the history of how we got here. We're going to talk about some of that here in just a minute, but the prior organization had a board of was not a government agency. It was a corporation that had a board of directors, and the board of directors had decision-making authority over the business operations of that organization. This function is now done by DCBS, which is a state agency, and our board of directors is the legislature, and we take guidance from them as well as the governor. So your role is different than that board of directors. Your advisory. Statutorily, you're advisory to me as the director, but you also have a direct reporting role to the legislature, and the history around that really is to make sure that you have independent voice to be able to tell the legislature if you think something is especially right, something is especially wrong, whatever kinds of things you feel that you need to communicate. Ultimately, though, I, working in partnership with the legislature and the governor, will do things like figure out what our budget is and hiring and firing decisions and all those kinds of things. But your role is really critical. And I don't want the notion that this is an advisory committee to make anyone think that, well, we're here to have a meeting and give you cookies and coffee and then go away and ignore everything you told us. The purpose of this group and the reason that the kinds of voices are around the table is to really create a forum where, in the public light of day, in a public meeting environment, webcast and all of that, we wrestle here with the issues that are important to wrestle with in the successful delivery of a health insurance marketplace. And when I think of the successful delivery of the health insurance marketplace, I don't mean that in the narrow sense of a website or the call center and associated functions that go with that. I really mean in the large sense of how do we get people who are appropriately covered by private insurance the most cost-effective, most health-effective coverage that they possibly can within that larger system. And so you've got just really a critical role, in the discussions that happen here need to happen here because this is a forum that brings those voices together and allows us to have good, well-rounded conversations. The last thing I'll say about that is the statute that created this advisory committee identifies a number of kinds of interests that need to be around the table. But I really encourage you not to think of yourself as the representative from that interest, that you're here with a perspective and you need to bring that perspective. But what we would really encourage is everyone to be thinking about bringing that perspective to the overall issue as a whole, and how the marketplace function needs to work in the state. So with that, we have a really jam-packed agenda. You have some business issues to do in terms of electing a chair and vice chair, adopting some bylaws, and then we have some substantive things to throw at you in terms of the assessment that pays for the marketplace, as well as some legislative work that was given to us around the basic health plan and some waivers, and we'll get to all that in detail. Because of that, we did not give you any time for breaks or stretching or anything like that. So I would encourage you to move about as the spirit moves you and your needs dictate. Water and coffee and that kind of thing in the back, restrooms outside. But before we go to the hardcore business items that you have, Barry and I thought it would be useful to take a few minutes to give you something of an overview, grounding in how we got here, where we are, and how things work, so that we can try to start at something of a common baseline. And these materials went out ahead, so Claire, I'm hoping that you've got some sort of copy of the PowerPoint there that you can refer to. Is that right?
I don't know if I have the PowerPoint, but I know I've got a whole bunch of material.
So if you go down through it, you'll find something that starts off with a title page that says Oregon Health Insurance Marketplace.
It's also the webcast. So
it's also on the webcast. You're watching the webcast. Yeah. So I'm going to try to drive the PowerPoint while looking over my shoulder to make sure I'm talking about the slide that's on the screen. It's a lot to keep in my head. And so what I'm going to start out, and then I'm going to hand it to Barry, but really talk about what is the marketplace, because this act, believe it or not, it's kind of a point of confusion, and particularly if you listen to a lot of political rhetoric out at DC, you hear lots of discussion about how we failed to get a website going. And people might be tempted to think that all Cover Oregon ever was a failed website, and running a marketplace is in fact significantly more than that, and that's part of what we want to talk about. Really what a marketplace is the ability to purchase plans, which you do through a marketplace, but it's also the ability to access subsidies, both in terms of premium tax credit as well as cost sharing subsidies. It's the ability to get access to adequate information to make an informed purchasing decision, as Cindy alluded to. And it's all the assistance that goes along with being able to do that. So formal call center assistance at the federal level for how do I reset my password and how do I work this system, but also call center assistance along the lines of, I just don't understand how this bronze plan could be that much different than this silver plan, and those kinds of issues that we deal with through our staff here, through community partners and assisters, as well as through the federal marketplace. And then there's all the work that we'll talk about in a minute around promotion and communication and plan selection and all those sorts of things. That's really what a marketplace is. I alluded earlier to the fact that we have been kind of on a rocket sled from where we were in the fall of 2014, when in September during legislative days, late September, there had been a bit of talk for a couple of weeks about would Cover Oregon continue to exist as an organization, which seemingly overnight, to Barry and I, turned into we should send these functions to the Department of Consumer and Business Services. And we spent a couple of weeks in denial and really kind of vetting, is that really what people think ought to happen? And that fall, it began to be clear that at least it was going to be something that was going to be seriously considered. And so I put Barry in charge of a small working team within the organization to begin to plan what might that look like if that were to happen. As the fall progressed, it became clear that it looked like that really was actually going to happen, to the point that we had legislative council drafting language and an interim committee established, joint committee established for that purpose. And so in December, we launched formal project planning with the staff of Cover Oregon to begin to plan that transition. And it's been a while since I've had the opportunity to say it, but I wanted to point out again The staff of Cover Oregon were incredibly dedicated professionals who did an outstanding job working under unimaginably difficult circumstances, personally and professionally, really working through the unwinding of their agency. I have a hard time imagining how I would have dealt with those kinds of circumstances, and the percentage of folks who stayed to the very end, who worked very hard throughout, despite the fact that there was an awful lot of unfair rhetoric and those kinds of things, is really to be commended. And a lot of why we're here and in a position to be able to do the things we're able to do now is because of those folks' professionalism. Senate Bill 1 passed and was signed by the governor March 1st, and it had a sort of a two-stage effectiveness. On the passage of the bill, the body of the Cover Oregon Board of Directors and the position of Executive Director were abolished, and I assumed that responsibility. So effectively, I became the last CEO of Cover Oregon. And the way we then worked it was I managed the wind down at Cover Oregon while Barry managed the standing up of the marketplace function at DCBS. So we tried to keep those, although well planned and coordinated, we tried to keep those somewhat separate so that she and her team could stay focused on successfully getting things stood up. A couple of other important features of the bill. The organization, Cover Oregon, ceased to exist formally on June 30th, and so everything was aimed toward that transition date. We were also very careful to maintain Oregon's status as a state-based exchange, regardless of the enrollment platform that we use. We thought and continue to believe very strongly that the advantages of the things that we're able to control as a state-based exchange far outweigh the added cost and other elements that go with that. And so we were careful in the design of the bill to make sure there was no question that we were a state-based exchange. And partly at the time that was because of a Supreme Court case that called into question whether tax credits would be available to federal exchange states. And so we were especially sensitive to that. That, of course, went the other way and isn't an issue, but the underlying policy remains the case. The other issue that's important to note is that there was some discussion about should this function be part of what was then the insurance division. We've since merged insurance with finance and corporate securities into a single division. But aside from concerns that came particularly from the insurance industry of not wanting to have the regulator also be the operator of the marketplace, I wanted to make sure that whoever was charged with being responsible for the marketplace only needed to focus on running the marketplace and had that as their singular mission, because lack of focus is the kind of thing that kills these sorts of efforts. And so it was consciously created as a separate entity, and there's language in the bill that basically says decision makers, aside from me, since I run the overall agency, decision makers in the marketplace have to be different from decision makers in the insurance division, so that there's two separate chains that go up to me, not a blurring where you've got someone who's potentially making both kinds of decisions. And so there are some real practical reasons for that. From a legislative standpoint, I think the biggest feature, look at that. The biggest feature of Senate Bill 1 is that this function comes back to being operated by a state agency and not by an independent corporation. That means I only get the positions that the legislature gives me. We only have the budget that the legislature gives us. If we want to go off and do a technology project, we have to go submit what they call a policy option package, or POP, in the legislature to get permission for that. We fall under the state chief information officer process for approving technology projects. We're covered by state personnel rules and state purchasing rules. All of that stuff that a lot of times gets described as a burden for state agencies also is a pretty great system for having a set of standards that you follow, and when you follow those, if you execute properly, you can keep yourself out of a lot of trouble. And so that accountability is back, and one of our legislative budget co-chairs is fond of asking if things go wrong, who does she shoot, and the answer is me. So there's an identified target, and she knows who to get a hold of if there are concerns. And that's actually helped a lot. That focus and that knowledge of legislators about how the system works, the great work that Barry and her team have done of successfully standing things up, have gotten us to a place that I never would have imagined that when we did a budget presentation in February on this, it was the kind of thing that they were having us hurry through because they had other higher priority, more important things they wanted to spend time focusing on, and there just wasn't that much to see here. Which, you do a lot of work and you think, well, gosh, darn it, I'd like to show you this, but on the other hand, it's like, no, that's okay. I think we're fine with that. We also, as a result of the bill, had some special reporting requirements. Some of them were really special, like we were drafting reports before we had delivered the version of the report prior, because we were required to provide a formal written report every time the legislature met during the interim up until February, and so we were quite literally delivering a report with half of a draft in the can for the next time, with a due date 7 days after the committee meeting where we provided the report. So there was lots of communication during the interim. We also have a requirement that if at any time we intend to spend over $1 million on technology, we need to personally notify each and every individual legislator of that intent. And that's in addition to the process both through the Chief Information Office and through the legislature that we need to go through to get permission to spend money on technology. So there's a strong bias toward lots of folks looking over our shoulders if we want to go spend that kind of money, and that's kind of for obvious reasons, I guess. Go ahead and turn it over to Barry.
Yeah, so Pat mentioned earlier that Oregon is a state-based marketplace, and it was really important for us to keep that credential. We're now officially called a state-based marketplace using the federal platform. And just for interesting exchange trivia, we are one of 3 states that has that unique identifier, New Mexico and Nevada being the other 2 that are exactly like us. And what that means, and it's important for this group to really understand what that means because it's the work you're going to be really involved with, is that I think we really do the work that touches Oregonians and the work that you really need to understand Oregon to do well. And we leave the work that's really more about technology and eligibility enrollment to the healthcare.gov site. So just moving quickly through this list, obviously we do oversight and administration and finance, which we'll be talking about later with regard to the assessment. We do things that really impact Oregonians through the Compact of Free Association legislation that you had in your packets and that Joe mentioned earlier, and through the Basic Health Plan bill that passed earlier that we're going to be talking about later. We partner with agents and nonprofits to make sure that folks are on the ground notifying Oregonians about eligibility and enrollment opportunities. And we also do a lot of kind of what I describe as boutique call center work. So the FFM really can handle very specific eligibility and enrollment issues and really get the people through the process. But we really help Oregonians who have really specialized issues, problems, who need that kind of hand-holding. In fact, just a great example, recently we saw a letter to the editor in the Corvallis Times from a consumer who just had some trouble and they just did not know what to do. And so we were actually able to find that person and offer our assistance, and we'll help shepherd you through the process. So that's the kind of just real service to Oregonians that we can actually provide specifically. On the next slide, we also go into a little bit of detail about some of the transitional work that was key to the dissolution of Cover Oregon and transitioning the functions to the Department of Consumer and Business Services. Obviously, there was that dissolution of the organization, the stand-up of the new marketplace, but there was also a tremendous amount of tail work that went into the dissolution of Cover Oregon, and that may or may not peek through at times when we're going through agenda items for this committee. But it's just interesting to note how much ongoing work there is when you manage an exchange. For just a couple of quick examples that are on here, many of you probably heard about agent commission issues over the course of Cover Oregon. We were able to wrap most of those up by June 30th, and so we were in a good place, but there was a couple of lingering issues which we still needed to work through. We also needed to obviously archive all of the Cover Oregon data so that we'd be able to provide information to consumers if they needed an updated 1095A or things like that. So we had to develop an archive solution to actually manage that infrastructure. So there's just a couple of examples of the lingering work that occurred with regard to the dissolution of Cover Oregon.
Barry?
Yeah.
We didn't ask if you wanted questions during.
Oh.
I had a quick question about the previous slide, the one about what transferred to DCBS. So I know we're going to have a separate discussion about the RFP in the months ahead. So not that, but if nothing else changes, is this list static or is some of this just temporary and will evolve over time, or is this pretty well set? Again, assuming we don't make any other major changes to our platform, is this?
I think this is pretty well set. Yeah. So back to you, Pat.
And as I alluded to earlier, we started the marketplace as a business unit within DCBS on July 1st of 2015. And I appointed Barry to be the administrator, and she a little bit before that and a little bit after that got staffed up. We were fortunate enough to be able to bring some of Cover Oregon's former staff on board. In particular, we brought the entire remaining call center staff for the first year of operation. Partly because we didn't know in the current circumstance what that work was going to look like in terms of volume and nature and those sorts of things. And we've actually now, with the February session, converted temporary positions like that to the extent that they're remaining as permanent positions. So we're now fully and permanently staffed. I talked about accountability to the legislature and the governor. I didn't touch on the advisory committee, but the advisory committee is a creation of the legislature. It is fairly unusual for advisory committees to be appointed by the governor and confirmed by the Senate. I think that's an indicator to you of the significance of the body of work that folks look to you to do here. Myself as director of DCBS and Lynn Saxton as director of OHA, our ex officio members. Mark Fairbanks is here representing Lynn. To the extent we do voting, ex officio doesn't mean non-voting, it just means by position. I would expect that I would probably mostly not vote, since I'm ultimately the recipient of the advice you're providing. But I would anticipate that that OHA's position would be a full member of the full participant in the committee. I think I've already touched on just about, I'm sorry, one last thing. As an organizational detail, there's another part of the agency some of you may be familiar with, called SHEBA, the Senior Health Insurance Benefit Assistance Program. It's a federally funded program that helps folks navigate the Medicare system. It's kind of interesting if you think about what SHEBA does. SHEBA, with a few staff here in Salem working through a large network of people out in the community, help Oregonians make decisions about complex choices they have to make about health insurance when it's paid for by Medicare. When you think about the marketplace, it's a few folks here in Salem working through a large network of incredibly talented people around the state, helping people make decisions about complex health care that's paid for by tax credits and private insurance. And we thought to ourselves, I wonder if there might be an opportunity there to actually have those functions managed together and actually find some opportunities. They have somewhat different open enrollment periods, some different skill sets, but if you work with that population, there's actually a lot of overlap in families and even in individuals of trying to navigate both those systems. And so effective February 1st? March 1st. We have merged the SHEBA staff into the marketplace. They continue to be separately federally funded, and so it is a separate program, but we're now working together in partnership and beginning to find ways to leverage those two very, very similar bodies of work with each other. Barry, is this one you?
It's not, but it can be. I better know our org chart, right?
Yeah.
I mean, I think this org chart is just a great illustration of really how small the team is here at DCBS. I think including the SHEBA program, we're 22 employees, not including the kind of shared services staff that work with us and with the rest of the agency. So that's just a good indication. And I also really, over time, I'm hoping that you all will get to know individually a lot of the people who work on the team, because I think that's the way to really increase transparency and have you really understand the organization and feel comfortable asking questions. It's not only to work with Pat and me, but also to work with anyone on the team who you feel like would be advantageous to work with.
The one comment I would make too is that there have been some comments about the relatively small staff we have for the marketplace function now compared to the relatively larger staff that Cover Oregon had. In fairness to Cover Oregon, that was organized as an entity that was going to be supporting and implementing a very large technology project and running a program. We're the program half of that without the technology part of that. They were a freestanding corporation that needed to provide its own human resources and IT and accounting and all those things. the marketplace here is part of a nearly 1,000-person agency that already has all those functions. And so it really is a bit of an apples to oranges comparison to look at the relatively smaller stuff. But we think we have a very efficient operation in terms of delivering those services. I think I've touched on just about everything on this slide about the advisory committee. I forget if it's supposed to come up here or elsewhere, but one thing to think about, you are now public officials by virtue of serving on an advisory committee. That means, among other things, you're covered by conflict of interest laws. There's sort of the narrow legal issue there, and then a larger issue I want you to think about. The narrow issue is you need to declare if you have an actual or potential conflict of interest when your personal financial circumstances may be implicated by something that you're making an advisory decision about here. So let's say there was some mythical future grant program that that this body would be advising the department on the structure of, and your organization could be a potential recipient of one of those grants. That may constitute a potential conflict of interest. If it's something where you personally are a candidate for a position, or I'm making this stuff up out of whole cloth, but you get the idea, you may have an actual conflict of interest. We can provide more information about how that works. However, everyone's here because they also represent an interest. That's not conflict of interest usually in the sort of the legal sense, but I think when we get to those kinds of decisions where there may be implications for organizations, it's useful to be candid about those so that people don't get a mistaken notion that what we're here is, you know, a bunch of insiders around the table making decisions that impact our own organizations, and kind of shining the light of day on those, I think, can be helpful. And so we'll create some structures for you to be able to do that. A couple of financial things to ground you in, because they'll be important later in one of the items that we have teed up for you. The marketplace has a separate dedicated fund, separate from all other DCBS funds. It's funded by one and only one revenue stream, which is an assessment on insurance premiums. We love the word assessment, but tax is an equally accurate word. In Oregon, it's denominated in terms of a per member per month fee, which is currently $9.66 on medical plans and 97 cents on dental plans. Most of the rest of the world and the federal world denominates everything in terms of percentage of premium. And there are some reasons we'll get to later about why we like our method of doing that better. But that $9.66 roughly equates on average to about 3% of premium, but it's more on lower premiums and less on higher premiums. We did a budget for the marketplace as Senate Bill 1 was considered. We've revised that budget a number of times. One of the action items we're going to have for you is a reduction in that assessment, dropping it from $9.66 to $6, or the dental from 97 cents to 57 cents. We'll talk about that in some detail later, but that's the funding stream for the marketplace function in Oregon. There are no federal grant dollars that we inherited from Cover Oregon. There's no general fund, no other source of money in the system. That is our sole funding source.
Can I just clarify something
Sure.
real fast? This is a subtle thing that I think it's important for people on the advisory committee to be aware of, that the per member per month fee is actually distributed across the whole market among the plans that participate in the marketplace. So it is not the case that an individual member that's signing up is paying $9.66 more than they would be if they were purchasing the same plan off the marketplace. That amount is actually spread throughout the whole individual market risk pool. So just sometimes people will say you shouldn't go to the marketplace because it actually costs more, but that's just not true.
Right. And it's not an assessment that shows up as a line item on the customer's bill. It's absorbed as part of the overall cost by the insurer. Also, if anybody dives into detailed descriptions of the marketplace budget, there are some large dollar amounts temporarily that have to do with cost sharing between us and the health authority on technology licenses related to the old Cover Oregon system that was in some version of use up until just recently. OHA moved over to its system for Oregon Health Plan enrollments at the first of the year through February, depending on what part you're talking about, and we've moved everything off from an archive standpoint at the end of March. So those products are no longer being provided, but there have been licensing costs that had a large portion that were paid for by OHA, and that flowed from OHA into our budget and then onto vendors. And if you are inclined to want to dive into budget stuff, we can answer questions for you, provide more detail. In terms of our financial performance, I was kind of fond for a while in the legislature of saying all of our forecasts were wrong. All of our revenue was higher than expected, and all of our expenses were lower than expected. So we did a pretty good job of being conservative in the initial budget for the marketplace. And that was before getting the enrollment numbers that we got this year, which were considerably higher than what we forecast as well. So from a revenue standpoint, we're in better shape than we expected to be at this stage.
How come that isn't highlighted on the top of the Oregonian's front page?
A rhetorical question, no doubt.
Yeah, no doubt.
This was the expense stuff that I just talked about. We've got a couple of potential future costs to talk quickly about. We still have a federal requirement to provide a small business health options program shop, and we're in the process of reviewing different technology options for the delivery of that, but there's a lot in play on that issue, and we'll visit that at another meeting. Also, because Barry mentioned this 2014 tail. It's this body of work that we'll need to continue to do for years because we operated a marketplace in 2014. So we're responsible in particular for tax reporting related to that. And as you know, you can file an amended return you can get an extension and have a period of years to file your return. You can do amended returns for a long period of time. And so for that entire period, people could either be coming in to change their return or be subject to audit and need records or make changes. And we need to be able to have the capacity to change that list of federal documents that we put up earlier with the IRS. That's an electronic system, and the security investments that are being required to maintain access to that system are ramping up significantly, and it seems like every time we interact with CMS or with IRS, we learn about new requirements that they're thinking about implementing, and those could drive some significant costs. So we want to make sure you're aware of that. And then that financial performance drives an ending fund balance that's higher. That's if we project it to be higher than we expected. That's important for you to know because there's a statutory requirement that the marketplace maintain no more than 6 months of expenses worth of an ending balance. That's an issue we want to visit with the legislature because we believe that's rather low. All of the other funds the department operates, we target between 6 months and a year worth of ending fund balance. But there's a methodology in rule now that provides for how that gets rebated back to carriers. We're actually proposing a change in that methodology to lengthen the period before we do that review. Partly to help change that math a little bit, but we expect to be in a refund condition actually fairly soon based on the current financial forecasts.
So Pat,
Yeah.
jumping ahead to the assessment conversation, if I can ask you a question here. Let's start with the tough questions already. Probably some of us are wondering, or I'm wondering, if we're already targeting to be well in excess, why doesn't that drive our assessment lower for 2017?
And that's why we've proposed to reduce the assessment for 2017. The reason that we're trying not to push that as fast as we could is we're also in the midst of considering whether we want to get back in the technology platform business. We'll have to do a lot of things before we would ever get to the place where we would go to the legislature, including having this body say they think it's a good idea, and ask for that. But if we are going to do that, it would be more useful to have built up a fund balance for implementation costs that we've not gone and rebated back. And so we're trying to buy some time to be able to have space for that conversation.
Gotcha. So that's one of the things that we can hopefully provide some advice on, because what I hear you saying is you're trying to find that balance between lowering the assessment, because that helps the market, but also making sure to retain some flexibility with the marketplace to do the things we need to do. To your point, you could drive that assessment down lower and try and hit 6 months on the nose. We've already indicated that's not what we want to do necessarily. We want to go beyond that. But just helping keep us apprised of that balance, because that's a tough thing to do, and I realize it's all projections, but you will have one camp that says drive the assessment down and another camp that says keep money available to do some of these things you want to do. So.
Yes, ma'am.
So I have a question with respect to any rebating excess fund balance. I know you made an earlier comment that insurers absorb the cost, but there would be some people who maybe doubt that and say that consumer is charged the cost. And is there no accommodation to a consumer in terms of the rebates back, or?
Yeah, no, it's a great question. And I'm going to try to not geek out on the answer in terms of how this works, but it works like this. Remember, I talked about keeping the marketplace function separate from the insurance regulatory function. And part of the insurance regulatory function is rate setting. And so the assessment is a part of what the Division of Financial Regulation considers when it looks at rate filings by carriers. And so the existence of an assessment at a particular level and the cash flow from any rebate would be factors that would fold into what kind of a rate increase or decrease was proposed by a carrier and how it would be responded to by the Division of Financial Regulation. That's kind of 3 steps of a pinball through a bit of a maze, but that's the mechanism by which we would work to allow for that. And then the backstop is if somewhere along the line, excuse me, we get that wrong, it would show up in increased reserve balances or profits by the insurance company, which we could then take into account the next year in rates. And so over the long term, we should have the regulatory mechanisms to assure that those rebates affect actual coverage rates. I'm sorry, there's one more backstop, which is the medical loss ratio, which requires carriers to put at least 80% of their premiums into care. And so if they start getting a bunch of money in rebates, that starts pushing that number out of whack. And so there are some self-correcting mechanisms that don't show up right away necessarily, but over a period of time should stabilize that. Are you buying what I'm selling?
Well, we'll see. I mean, there's a lot of trust in there.
Cindy, the other thing I'd suggest is, and we may want to ask Pat Berry to bring this to us at some future point, there's been a lot of discussion with the former insurance division that they believe carriers across the board are losing money in the individual market, whether it's on exchange or off exchange, and that's why they do that rate setting. So I would say to the extent that an assessment drops down, what that's really doing is reducing the losses, and that consumers in the individual market already in some sense are being subsidized by the margins that carriers make in other markets. So, they're serving Intel and Nike and self-insured groups are making money there. They're frankly serving other state programs where they may be making money. Some of them are making money in Medicare. So there's a lot of other areas that the carriers, I think all the major ones that in our marketplace are bringing, they're managing it across their whole portfolio. And one of the challenges that Pat and Laura Callie have in particular is trying to create some sustainability just within the individual market.
Right, and I appreciate those things. I think there are so many moving pieces, especially in the individual market at the different metal levels, and really who is paying for what and who's subsidized and who is not.
Absolutely.
And so I am a little bit just concerned about how all of that washes out. And I know you can gather a lot of data and hide a lot of important stuff, not by design, but it looks like we are dealing with old data with respect to enrollment. If we're looking at 2014 enrollments, that's kind of prior to ACA. I'm concerned about that, and then how the meta levels, who pays for what.
Yeah.
So,
think we just covered all of that, so I'm going to skip ahead to technology and just raise a couple of points. As we talked about, we have a request for proposals that's out that we've received responses to now to assess the technology available and its cost to deliver SHOP, as well as the technology and its cost to deliver an individual platform, and we're not prepared today to be able to talk about that in significant detail. However, there's a number to keep in mind that we're trying to keep our eye on. I talked about that assessment, that $9.66 per member per month, that we roughly equate to about 3% of premium. There's a statutory cap on what we charge that is 5% of premium. That does not cover, the cap does not apply to what the federal government charges for use of its platform. It proposes to charge 3% of premium for the use of its platform with a low introductory rate of 1.5% for the first year. While the cap doesn't cover that, we're, from an operational standpoint, adding that charge to our charge and looking how that compares to the 5% cap, because the way we look at it is policymakers set that 5% cap as their cap on the total cost of the system back when they thought we would operate the technology. So whether it's legally covered by the cap or not, we would like to try to deliver a system for a total of 5% of premium or less. So even if we do nothing, the 3%-ish that we charge plus the 1.5% in the first year would bring us in under that cap. And we're going to talk about a proposed reduction that would get us really close to where we would want to be for years going forward. We also don't know what the federal government will do with that charge in the future. But that's kind of the range of what we're looking at. But it's important to understand the 5%. Not so much as a definitive legal cap, but an operational target that we're using because of what it represents. Let me stop there because I know that's a little bit dense, and ask if there are questions about that.
And so the RFPs that we've let, some are for the potential SHOP, and some are potentially to replace healthcare.gov with our own possible, okay, in order to take a closer look at that potential 3%.
Right, and one of the questions we need to be able to answer is 3% for the federal platform a good deal?
Yeah.
Right. There are other questions beyond that, but that's one of the most significant ones. All right, I'm going to turn it back to Barry to talk about open enrollment for 2016.
And we're going to do a lot of conversation about outreach and education at the May meeting, and so I'm just going to go through these last 4 slides just very, very quickly and just kind of give you a high-level backdrop on open enrollment. We had just a phenomenal 2016 open enrollment. I think Oregon ended the 2015 open enrollment period with something like 112,000 lives, and we ended the 2016 plan year open enrollment period with 147,000. So I think that was a 31% increase over the 2015 numbers, and Oregon finished #1 in the nation for among FFM states. So for other states using healthcare.gov, we had the highest percentage of increase over any other state using healthcare.gov. And people can attribute that to all kinds of things. I attribute it to our great outreach and education work. So I think that some things you'll just want to be thinking about as we work on these issues together is that we do not have a lot of money to spend on outreach and education, which means that we have to target every single outreach and education dollar in a very measured way. So we take, extensive research into consideration. We do all kinds of planning, then we do our outreach, and then we come back and evaluate it using the data we received, and then we reconfigure, and then we go out again. So a lot of the information you're going to be seeing over the next few months is really based upon a lot of data that we pull together to make those kinds of decisions. And you can see a lot of that in the slides that we provided for you. We had, 147 million ad impressions served to Oregonians, which is twice the industry average in terms of click-through rates, meaning that consumers are really driven by the ads that they see. We share a wonderful website with the Oregon Health Authority, and we get a huge number, as you can see, of website sessions on there. We had a tremendous amount of earned media during the campaign. and had just a really wonderful partnership with Oregon agents and community partners to really make sure that Oregonians had that local help, which is really what they have said they want in order to be successful in enrolling for health insurance. So it was a great campaign, and we're really looking forward at our May meeting to not only doing a deeper dive on kind of what we learned for the 2016 open enrollment period, but also telling you what we're planning for 2017 and really getting your feedback in terms of what you think would be effective. So I think I'll just kind of stop there. And
I've done the last thing I'll touch on.
Quick question on that.
Sure.
Are we doing the marketing in-house, or are we contracted with some other entity?
Yeah, we work with a firm called Grady Britton out of Portland, and they also work, and we also work with Metropolitan Group, and it's really kind of a two-tiered approach to outreach. There's the formal digital media, digital advertising that Grady Britton helps us with, and then there's really more of a community-focused local outreach effort that Metropolitan Group helps us with. So yes, they're great partners for us and have been very helpful.
A comment about that, and I know we'll go further into it in the May meeting, but just something to keep in mind in our area where we don't have a local Oregon even news station, there was hardly any marketing done for Cover Oregon or the marketplace. So just something to keep in mind. We want to make sure to cover all areas.
Maria, that is great feedback, and that's actually exactly why our agent program is so important to us, because what we've heard, and I'll want to hear more from you because you actually live it and know it, is that really it's actually having those trusted advisors in the county, in the city, at the library, and that's our outreach center, as you'll learn more about in the coming months. Actually, each of our individual outreach center folks are out there in the counties, meeting with libraries, meeting with county health departments, and trying to build those relationships so that those trusted advisors can be relied upon by the Oregonians in those areas. Because that's your experience is exactly what we've heard about. So,
Go ahead, Cindy.
I think this was really great effort and good result, but I was curious in reading this. So do you have any knowledge of how many people are not covered?
yes, we're just based upon the 2016 Plan Your Open Enrollment. So like, what's the data to date?
Right, like 147,000 Oregonians were enrolled. So who didn't you hit? What?
Right, that's a really good question. And so as soon as open enrollment ends, we start to receive all kinds of data from all kinds of different data sources. And last year we relied upon the McKinsey Foundation to do exactly that for us, to tell us who's still uninsured, how many people are actually subsidy eligible among those uninsured population, what's the demographic of those folks. And so we're in the position right now of collecting all of that data. And at our May meeting, we hope to be able to come back and say, here's what we've learned to date. I mean, I can give you kind of broad numbers. Like, we think there's something like 360,000 people eligible to purchase qualified health plans in Oregon. We think among those people, there's probably 216,000 who are subsidy eligible. So I can give you kind of those broad strokes right now, but in terms of, we like to get pretty granular down to the county level.
And just to follow up on that, so given the research you're doing, will there also be a look at, there were people who signed up during open enrollment and maybe sign up for, you're not subsidy eligible, you sign up, you just simply can't afford the premium, and so you drop your cut. Will you have that?
We have that data too. Because there's an attrition that occurs throughout the year. We start out at a high number and it kind of goes down. And so we can provide monthly enrollment reports to show whether or not we're losing enrollees. We don't always know why we've lost a specific enrollee, but we can often see trends. So, yes, absolutely.
Joe and then Jesse.
Yeah, quick question. Is there a way that you also track the demographics of the people you're enrolling, kind of by race, ethnicity?
We do. We have we have data from the federal marketplace on just that answers exactly those questions. Not everybody answers all of those questions, so some of it's unreliable, and we don't always understand why population percentages and FFM percentages vary or differ. But we do have that data, and that's another thing we'll definitely bring in May.
Yeah, I think it'll be very important also in informing how we are doing outreach and which communities are being missed, which communities we need to focus more efforts on.
And we'll have the annual marketplace report is nearly done, and that's something I'll be sending out to all of you in the next couple of weeks. And it has just a tremendous amount of really good data, which is what both of you are speaking to. So we'll have it even, I guess, before May.
Jesse? I was just going to say, it seems like one of the things that we're learning about how these marketplaces operate nationally is that there's always going to be a fair amount of churn in and out, and some of that is people not being able to afford their coverage, and that's a problem, and we need to do something about that. But part of it is just that, people sign up because they don't have coverage elsewhere, and then they get coverage elsewhere. So they, leave because they go on Medicare, they leave because they go on Medicaid, they leave because they get a job that has coverage, and that's all fine, but we don't have any good data source that tells us who's in which of those buckets, really. I mean, with Medicare, I suppose we could take the age, but the other pieces are pretty hard to track. So I think we're still, nationally, no one's quite gotten a handle on that yet.
Let me touch on the last slide that we have and then open it up for other questions you have. We had two pieces of legislation that affect the marketplace that passed in the 2016 session. In a coincidence designed to torture dyslexics, they're virtually the same number. House Bill 4071 is the Premium Assistance Program for Compacted Free Association Islanders. It basically provides Medicare-like benefits for legal residents, but who are not citizens, who are not eligible for Medicare and Medicaid, we'll be operating that, getting that program up and running. And then we're going to talk in more detail later in the agenda about House Bill 4017, which does two things. It creates the charge for us to develop a roadmap for blueprint for basic health plan. We'll talk about what all that means, and also consolidates discussions here around waivers under Section 1332 of the Affordable Care Act, or waivers allowed under Section 1332, which allow us to do stuff that's different than what the law provides for. And those both have advisory components that we'll talk about. With that, I'd stop and see if we've covered an awful lot of ground awfully fast. But I'd see if there are questions you have either about anything that we've gone by that you haven't already asked, or questions you came here with that you really wish we had addressed that we hadn't. And maybe I'll start and see Claire on the phone, or any questions that you have.
There was actually a dialogue that popped up there saying that she had to leave.
Oh, that's right. She was going to be with us for the first hour. That's right. So she doesn't have any questions. Are there questions?
The COPA bill was removed from the agenda for today. Is that going to be discussed at the next meeting as well? Or?
Muted.
unmuted.
I'm assuming isn't going to preclude us discussing that and having something to say about that.
Great
It's not
question.
just affordability.
I know in California, the exchange in California is moving aggressively on a quality strategy.
Yes, and I suspect we are here too.
We
I
would
just
like
wondered
to,
if
I
it
would
needed to
think.
be
Yeah.
specified.
So does it need to be in the bylaws? What's your sense of that?
I don't think it does. I don't think it needs
Okay.
to be spelled out.
No, I think the bylaws are capturing the minimum things that you must do,
Okay,
but you're free to do things. There, I don't think there's a you shall not do list.
okay.
Yeah.
I just didn't want it to be limited.
I do think it's important that that it's clear that that list of things we have to do. We are required by statute to do all of those things. So it's not including these among others, and we may or may not get to all of them. We actually have to do all of those things, but we may take other things on as well.
Okay.
Now, I just said something that's not quite true, which is that there's not a list of thou shalt nots. There is a limit in that you don't have the unlimited ability to task us with work on your behalf. We would love to do work on your behalf, research, those kinds of things, but there may come a point where it's okay, well, we can do either that project or this project. We don't have the resources or staff or time or money or whatever to do both. I say that because that in workers' comp, not surprisingly, that kind of thing does periodically come up where there's a desire for us to manage more than we're capable of. And we'll try to make sure that you're well aware of that. And we have a conversation about that sort of thing if it happens here, and I think that's relatively unlikely, at least early on. Dan, you're looking for hands now.
Yes, sorry.
Sorry, no problem. I noticed that under Article 2, Section 5, it does mention that we may hire experts to help discharge duties
And that's the
at the
exact point
discretion
that I
of
just,
yours.
Cindy.
Back to Article 2, Section 3. The last point, the affordability of health benefit plans offered through the marketplace, there's a similar one for health benefit plans offered by employers. I just want to make sure I understand it, that the affordability of health benefit plans does not just include premium cost. It includes the cost of the plan, really,
accessing the plan.
Accessing healthcare through the plan. So, and sometimes I find people who narrow it to affordability of the plan itself by premium, but it's the rest of it that.
And for some, the premium is not the biggest barrier, it's the cost share.
Absolutely,
Yeah.
absolutely. So, and again, I just think we're going to see more of that with the bronze level plans.
Bronze level plans.
Yeah.
You've experienced that.
Yeah, exactly. So.
Great point. Yes.
So Section 1, Article 2, Section 1, seems like we have a lot of duties, really, really broad, our scope and what we're kind of responsible for and being potentially held accountable for doing. But then Section 3 really narrows those things down. But it sounds like more could be added to that. And I guess maybe from how the senators made me feel that we do have a pretty big responsibility, how would things that then become a responsibility to advise on be laid out, and would we vote on them, or would we potentially be tasked with something that seems like a little out of our league, or not something that,
Great question.
How I really envisioned that is that we would obviously be bringing things that are in the normal course, kind of like the COPA issue and the basic health plan issue, and then always an assessment, because that actually is spelled out. But then I'd also be working with Pat, and I'd be working with Dan and Jesse to define things that this group might be interested in. It's within our scope, but that we may not have considered. In fact, it was great in some of the conversations I had with several of you. Jim was interested about quality ratings, and so I kind of shared some information about what we're doing with that. And I think Maria asked about minimum wage, and so we've been kind of trying to think about how we could provide information there. So I think it'll be a natural blend of both, and just an ongoing dialogue about stuff we kind of have to do, and then stuff you're interested in.
But just to be completely candid, I think part of what you're struggling with is some of the comments you heard during confirmation. I think
definitely, yeah.
I think would have been more appropriate were you being appointed to a board of directors with a board of directors kind of authority.
Definitely, but I guess the perception is more my concern too.
Yeah.
We are all in the public and in our communities and everything else saying we want to participate in this and be a voice.
Right.
So I guess just making sure we're all on the same page with what we are you know, and it seems like it's not necessarily set in stone, so other things could come up. So.
Yeah, I think the minimum is set in stone, and then
Definitely.
the maximum is really a conversation about what do you want to get into and what do we have bandwidth for.
But I guess going up to section 1, so Article 2, section 1, it seems like it could be really broad,
Mhm.
right? And so as a layperson reading that, it seems like, man, we could be responsible for all sorts of things, but.
So this is a great point, and you know, especially given the history of Oregon's exchange, I think we're all feeling this is important. And I think one of the things we as a group can do is be really clear about our meeting agendas, what's on and what's not. We can be clear in our communication, both through the staff and maybe through some of us ourselves, back to the legislature, be clear, this is what we're addressing and this is what we're not. And I think we need to be extra clear, more so than we might be otherwise. So I would encourage you and others, keep us focused on that. And if we do send a report to the legislature, are we not only talking about all the great things that we've done, are we clear about what we're not doing? So that no one's going to come back to us and say, we thought you were designing.
Exactly.
Yeah. So let's just be real proactive about addressing that and make sure that there's no misunderstanding about what's on our plate and what's off our plate.
To just add to that, the responsibilities, but also the liabilities. Because based on the comments from the senators, there's some liability implied.
I'm going to maybe put Ted Falk on the spot. He's our attorney from Department of Justice. Are you in a position to briefly comment on the liability of citizen volunteers on an advisory committee?
Sure.
You want to come up to the,
Maria, you may mean it's not just in a
why don't you come up to the table?
in a reputational sense.
Yeah, that's right.
Yeah.
And go ahead and introduce yourself.
Yeah, I'm Ted Falk with DOJ, and just so you know, I provide legal representation in the marketplace as well as most of the other insurance functions of the state of Oregon. As citizen volunteers, you'd be protected by the Tort Claims Act, and so honestly, I can't even think of a case where there was personal liability. If I may be candid, the liability that you face is public relations liability. I mean, your name could get in the newspaper. We can't defend you against that. So I think that's really the exposure.
But Ted, to the extent that Maria was referencing reputational liability, you know, any advice you can give us going forward about how to be clear so that those legislators don't come back to us and start pointing fingers about what we should have been doing or not doing. We're all nervous about that after our hearings.
I appreciate your asking the question. I think Pat would be the right person to answer.
Hot potatoes.
Some attorneys you can pitch a hot potato to and they'll catch it. I understand and appreciate the risk. I think that one of the benefits of this being with an agency is that if things go off the rails, either for reasons that you foresaw and warned us about or for reasons completely unforeseen, the natural tendency of the body down the street is to hold the agency and its staff and director accountable and not look to people on a broad advisory committee as the people who should have been paying attention. That I think that really is different than with a board of directors where there's a fiduciary responsibility and not just an advisory responsibility. Now, I understand it's your name, well, it's your name and mine, I guess is the better way to put it. But you know, I think be aggressive about the things that you want information from us about. Be willing to provide whatever your opinion is, and not, you know, you worry about what you think you should tell us, not how you think we're going to hear it, or you know how it's going to get packaged and used, or those kinds of things. And that's what your job is. And if you do that job, you'll help us avoid those kinds of problems, and you'll be able to, you know, look with a clear conscience at whatever comes from that, and say, you know, you did your part. And I mean, that's probably the most I can really offer in that sort of context.
So we have about 5 minutes left, 4 minutes for this discussion. I want to just leave the floor open for another minute. Any questions, concerns? We've talked through some good issues just in our short time on this topic. Any others before we move to a decision point?
Just continuing with the bylaws on section 8. Sorry, not section 8. Section conflict of interest. Oh, sorry, Article 4, Section 4. Or Section 3, I'm sorry. And it's last sentence, in accordance with ORS, the chairperson may convene an executive session during a regular, special, or emergency meeting. What is?
So that's boilerplate language. The state law provides for executive sessions where you can exclude the public from a meeting, and there's a statutory list of the reasons that you can validly do that. I can't imagine that you would ever have a valid reason for doing that, because there are things like personnel discussions, real estate transactions, legal advice, those kinds of things. And you would have to have a statutory reason that you can point to go into executive session. So this says that it's theoretically possible. From a practical standpoint, I would be hard pressed to think that you would ever be in a position of being in executive session.
Thank you, Cindy. Other questions, comments, concerns? Jesse?
We already talked a little bit about the conflict of interest piece, and I just wanted to clarify. I mean, I think what's in the bylaws is fine. I have no objection to it, but it would be helpful to have a little bit more clarity about how to declare a conflict of interest and when to do so. And I think that could be done in a more informal way through the bylaws. But I think that, when this is a multi-stakeholder group and we have a bunch of different interests that are impacted by our decisions in a whole bunch of different ways, and it may sometimes be a little bit unclear when people need to declare and when they don't.
And Barry, did the packet already include information on that, or is that something we can provide in the future?
We can definitely provide that. Maybe some examples would be helpful.
Yeah,
we can definitely do
Doesn't
that.
DOJ have a standard packet or training, Ted, they could provide us?
I think probably the best source of information, there's a publication by the Government Ethics Commission, and I forget the exact title, but it's like Government Ethics Law for government officials, and it kind of expresses everything in kind of plain language. So I think that document, which I think is updated every 2 or 3 years, would be the most useful thing.
We'll get you some resources and materials.
How do I access something online?
Was it through your training by chance that the governor's office provides? I believe that if you've taken the governor's office training, I believe some of that goes into that detail too.
Yeah, it was all seemed to be conflict of interest.
Yeah, but we can definitely provide some more information.
Okay, I want to make sure I give a lot of air to this because for reasons previously stated, I want to make sure that nobody feels rushed through this. However, if we feel like the bylaws look good to us and we're ready to approve those today, that can be our first official action. So any thoughts about that? Are people ready, want to vote, or people feel like they need more time?
I would make a motion to approve the bylaws.
Motion to approve the bylaws, seconded from Joe. Thank you. Discussion? Okay, with that, there's a motion on the table to approve the bylaws as drafted and distributed. All those in favor, please say aye.
Aye.
Opposed? Bylaws approved. Excellent. Right at 2:30. Thank you very much. Hopefully it's not all downhill from here.
Look at that. I turned the chair over and you're back on time.
I wasn't going to point that out, Pat, but I'll share that with you privately, but yes.
Just to point out, as we go along, I mean, there is an article for amendment. So there is an opportunity to amend the bylaws too.
Yes, absolutely. Good point, Steve. Okay, in terms of the assessment, Pat, was the plan that you do a quick, I'm trying to remember.
Yeah, I was going to kind of get to you what the assessment is and why it's important. We've talked about it a little bit already. But the assessment is the single source of revenue that pays for marketplace activities. As I indicated, it's currently set at $9.66 per member per month on medical plans, 97 cents, I believe. I don't have the think sheet right in front of me on dental plans. That gets factored into the cost of insurance. And so it's a number that you should pay attention to because it has an impact on affordability, albeit a relatively marginal one, based on the stuff we talked about in the overview in terms of revenue being higher than anticipated and expenses being lower, and with higher than anticipated enrollment. We're recommending a reduction in the assessment to $6 on medical, and I'm sorry, how much on dental?
56 cents, I think.
56 cents on dental. We believe that that's a level that's adequate to provide for the ongoing operating costs of the marketplace. Reduces some of the pressure on the rebate issue that we talked about previously, and when added to what we expect the federal platform cost to be for the first year, keeps us under that policy target of 5% of premium.
In this particular, the rule that we're talking about today, what it does is says that the agency can evaluate whether or not there needs to be a rebate based upon that allowance to keep 6 months margin at the end of our biennial state budget cycle, instead of at the end of a calendar year, which is how Cover Oregon did it. In an ideal world, I don't think you would talk about something this technical at a first advisory committee meeting, but of course we're in the middle of our assessment development process, as Pat has described, and so it was just really, it was timely and important, especially since that is one of the minimum things that this advisory committee does, that we talk about this rule. So this essentially, what we're wanting to do and really asking your advice about is, do you also think it makes sense to do that evaluation of a rebate at the end of a state budget cycle versus at the end of a calendar year when we haven't actually completed the entire budget?
Yeah, and I mean, being completely candid, it will cause more fund balance to build up until we do that assessment. We've talked about the fact that if we were to head down a path of doing a platform, that would be funds that we would need to go to the legislature for permission to spend, but they would be there to be able to spend for that purpose. So that buys us a period of flexibility.
And this rule was obviously originally written for Cover Oregon, which operated on a calendar year budget cycle, so it made sense for them, and it just was one of those things that's kind of in my mind, really a cleanup as we transition the budget to a state budget cycle.
It's like a stage on necessary paperwork as well.
Yeah, how would that play into, I guess, the carriers setting rates for following calendar years? I think a really big issue is just fluctuation. It's this, and then it's that, and then it's this, and then it's that, and that just creates so much heartache for consumers and everybody else involved. So I don't know if the representative of the carrier would have any information on that.
Gives us heartburn as well.
Yeah, I can imagine. Yeah,
Heartburn all around.
Yeah.
So the question was, how does the assessment flow through to the rate review process, and does that drive any volatility in the rate review process?
Yeah, and would it change? You know, it's changing it to not a calendar year.
Yeah, so by doing it every other year, we're actually reducing the volatility because you won't have an annual factor for potential rebate. You'd only have an every other year factor for potential rebate. Also explains why we need to do it now, because the rate filings are being prepared right now.
Right, but then it's coming mid-year. I mean, it's just changing the year cycle too, right, instead of a calendar year.
So the rate assessment is done the marketplace assessment is done every year, no matter what. And that happens always before rates are finalized, which is why we do it in the early part of the year. And what this does is it just essentially, as Pat explained, extends the opportunity for rebate. So they're used to getting the marketplace assessment rate every year and factoring that into rates. And then what they'll now become used to is at the end of each biennium, and they've never become used to anything because there's never been a rebate before. But if there were to be a rebate, it would be watching for that rebate at the end of the state budget cycle.
And there's a difference, I think to your point, there's a difference between when we say what it will be, if there is one, which needs to be before rates are filed, and when it actually happens, which it's not a problem for them to start in July as long as they know back in April that it's going to happen.
Okay, perfect. Yeah.
And maybe that gets to the issue of December versus July.
Well, and wouldn't it be nice not to get to a point that you kind of know the revenue, know the expenses, so there's not a rebate? I mean,
yes.
You really don't want a rebate situation. And I just want to mention, I applaud the $9.66 or the rate as opposed to a percentage.
Absolutely.
For that reason, that there's a number to manage as opposed to increasing premium costs. There's a perversity.
Well, we commented to the feds that when they were proposing their rates, we suggested that they were actually giving themselves an incentive for there to be higher rates,
Exactly.
or the appearance of that at least.
Exactly. So I applaud the effort to keep it as a.
Yeah, and to be clear, I was using the change in rates as context setting, but this rule is simply about the rebate calculation mechanism, not about the rate itself.
Yeah, I just wanted to make sure.
So to that last point, just so I'm clear, This rule is just about the rebate process. What's the status of the rule on the assessment? Is that pending, proposed, done?
It's pending.
It's, yeah, it's actually being filed this week. So,
And what's the relationship between that rulemaking and this rulemaking and the advisory committee? Since this is new to us, is it information? Are we being asked to weigh in and vote? I know that the rulemaking is a separate legal process that occurs outside the advisory committee, but you guys thought about how it relates to our work and what you need from us?
Just, you mean in terms of just this one today, or in terms of the?
I would say both
filed,
going
okay.
forward. So what do you need from us in terms of, want our opinion, obviously, but what beyond that?
So I mean, my experience with, and Pat, please correct me if I'm wrong, with rulemaking advisory committees is this is really a chance for you to kind of clarify, is there anything we've forgotten about? Is there anything that doesn't make sense? Should we be taking a different look at it? So I've never seen an advisory committee really vote about a rule, but doesn't mean it couldn't happen. But it's really just, is there anything here that just doesn't seem right? So.
Well, I'd make two comments. I have been involved in advisory committees where there are votes about rules, so that's however you want to be able to do that, but at a minimum, that notion of advice about the rule. Because we're sort of catching this spear in midair from a calendar standpoint, this is a little different than we would ordinarily try to do this going forward. We would try to have more time and more foundation on the mechanism question. And the rule filing on the rate, that's the finalized rule. So that one was moving on a pace because of rate filing that we needed to do that without you. Next year, we would expect to actually have a fairly in-depth discussion about the financing of the program, let you get under the hood in terms of budget and those kinds of things to the degree that you want to do that, and provide us meaningful advice on whether you think that actual assessment rate is the right rate or not. The calendar just didn't allow us to be able to do that with you this time.
Yeah, that's really helpful, because what was missing for me, you gave us very high level financials, but what I'd love to see, and I think all of us going forward, is to see the financial report of the marketplace, how that translates to an assessment going forward. And that's what I heard you just describe. So that sounds great. I understand, as you said, we caught it right in the middle of the process, so that it wouldn't be meaningful for us, given the timeline, to go back and look at how did you get to where you are today, because that's where you are today.
Right. But process-wise, there isn't going to be a separate rules advisory committee on any of these issues. We are just going to be like
you are the rules advisory. We'll use you as the rules advisory committee, unless we bring you a topic where you say, hey, time out, this is way too complicated for us to deal with here. We'd like to, we'd like you to set up a separate committee, or we'd like to set up a committee, or there's certainly room for that sort of thing. But when possible, we would like to use this as the advisory committee for marketplace rules.
So Pat, will you need legislative approval, and will you be proposing for 2017 a piece of legislation that allows you to change the fund balance that you hold? I know you made several references to that 6 months is not.
Yeah, we don't have a 17 concept in the hopper for that. We may find a target of opportunity to add something to some other bill that might deal with that. I think more likely we're going to go ahead and use this rule as the way to buy us enough flexibility to get through the next couple of years. And then once we've really been firmly running this in our shop and with our forecasts and management and those kinds of things, really see if we think that 6 month issue is really an issue and needs to be addressed or not. So probably not this time, but potentially in the future.
Thank you. Do people have feelings about the balance that Pat and Barry have described about, obviously the intent of the legislature was not to have unlimited fund balance hanging out at the agency?
Well, actually, let me correct that just a little bit, because it's that unlimited fund balance at the agency. It wasn't an agency, which is why the unlimited fund balance, I think, was something that attracted attention. I think it was unlimited fund balance at the semi-independent public corporation. And I think the fact that it is, in fact, now an agency changes that dynamic a little bit, and that's the argument that we would come back and make if we want to pursue this issue.
Good. If I'm understanding correctly, this is somewhat inconsistent with other agencies that might have a 6 month or more than a 6 month.
I don't want to say that. I will say in DCBS we have a number of statutorily dedicated funds, which mostly do not have statutory provisions for how much they can accumulate. And as a matter of policy, we have an upper and lower band that we target of 6 months to 1 year of expenditures as the fund balances. And in a perfect world, we would operate this one in a similar fashion because we find that 6 to 12 months range to be prudent. You know, the longer the boom goes, the higher you want to get toward 12 months and those kinds of things. I can't speak to fund balances at other agencies.
So if there is a rebate at the end of the budget year, which sense to me as opposed to a calendar year, it's figured on a date certain that okay, we had 10 months instead of 6 months. And so the 4 months is distributed. When the next month, it could go negative. I mean, you could, you know, if something.
Well, it shouldn't go negative. It could
Or
go
lower,
below 6 months.
Below, so then you,
Yeah. Hopefully we'd be better than that at math.
yes, hopefully there's nothing that big of a surprise.
Yeah.
We were reaching for a wall.
And just another quick question, I just want to make sure I have the numbers straight. So for 2017, the $6 proposed fee, you're saying $72 a year times this many enrollees gives us the revenue we need for that period.
And I would expect that as we get into late 2016, early 2017 with this group, what we'll do is we'll come back, we'll start to take a closer look at the financials. We'll be towards the end of the biennium, and we'll get ready for that decision or supporting or advising on the decision that the agency will have to make about what to do in June of 2017. That's at the end of the biennium, and looking at a fund balance then. And by then, we'll also have clarity on some of the policy options that we're going to talk about that may impact the fund balance, like the platform issue, SHOP, and other things. So it's good. This is a sort of a grounding discussion. It's good for us to ask these questions, and then going forward, we'll be able to really understand how that assessment is working.
Also, Dan, I'll send out the financial analysis that went into the $6 decision that the less formal advisory committee looked at, just if folks are interested and want to just kind of see that for homework.
Yeah, I think I told you the consultant report was outstanding. It's very complex. I had to read it a couple of times,
yes.
But it was very thorough, I thought.
Yes.
Dan? Yes. I think my only contribution would be to ensure that we keep enough of a reserve for the kinds of development that we've talked about, like with the technology, potential for things like that, because we're just starting. We're not sure that there aren't going to be opportunities that we don't want to miss because we don't have the reserve, and it's going to be a lot easier to go down later than to go up later, and that. But I think we've done that, so that's just the final thing. Is I feel confident that you've done the work that says that if we move at the pace you're describing, that we should be fine with that, and we don't need to go any lower. And I like the marketing potential for what we're proposing, frankly.
It also provides us a bit of a cushion for other risks. We're going to face a change of administration one way or another, and there are all sorts of potential outcomes.
You mean we're a single payer?
Right. There are all sorts of potential outcomes from that could occur suddenly. You know, I look at Kentucky's experience.
Yes.
Where on a dime they changed from one of the most successful state-based exchanges to abandoning it completely. And not that I'm suggesting, I'm talking about the federal administration, not other things, but having a little bit of money in the bank to ensure against those kinds of changes, I think is helpful too.
So Laura, Shauna, Shannon, Marie, anybody? I want to make sure everybody has a chance here to weigh in. Mark, we know you have an opinion about state finances, so just pause here and give people a chance to weigh in. I know we're probably all still in absorbing mode, which is great, but
I know I have already said some stuff, so if other people want to chime in, that's fine. But I have what might be a kind of dumb question about the way this all works, which is if the 6-month limitation is on expenditures, and that's how it's defined, it seems like if the agency took on a bunch of new work, that would be like that denominator or whatever would grow, and so we would actually have more flexibility. Am I misunderstanding that?
No, you're understanding that correct. This is master level state budget understanding, but to spend money in state government, you have to have two things. You have to have money, which we usually call having revenue, and so we've got the ability to set the assessment, and that generates revenue. After the fact, the legislature gets to check our work on setting that assessment, and they could tell us we were wrong and make us give whatever money we got back from a change in the assessment. But you also have to have what's called expenditure authority, or permission to spend the money. And so we can't just go decide to do more work and spend the money we have. We have to go to the legislature and say, we would like you to give us the authority to spend this much money on this new work. So the COFA program is an example of that's a new piece of work that actually has money associated with it, so it's a little bit different. But they gave us the permission to spend the money and then allocated general fund money to go do that work. So you have to have both. You got to have permission and you have to have the revenue. That also explains how it's impossible as a state agency for us to go run off and decide to do a technology platform without anyone deciding that we should do it or not, because we don't have the money in we don't have the expenditure authority in our budget to be able to do it, even if we have the revenue.
Right, and that includes personnel as well.
That's correct. That's actually sort of a third separate thing. You've got to have what's called position authority, which is permission to hire people.
So I want to reiterate something Pat said. The original focus on the assessment was really with regard to Cover Oregon as an independent public corporation, if you will. And, you know, the legislature was thinking, how do we control, since we're not doing position control or budget control? So I think that thematically what you're reminding us is now that the marketplace is back in a traditional state agency, the legislature has lots of levers they can pull. And the assessment is just one that they may use, but more likely what they would use is your budget expenditure authority to say this is what we want you to do, nothing more. So the assessment is still important, I think, for a lot of us around the table as consumers, producers, carriers, because that's what we're thinking about as the cost of the marketplace. So it is important that we have a robust understanding and discussion, but to Pat's point, it's not really the control lever that it would be if Cover Oregon were still in a public corporation, and the only thing the legislature could do is control that assessment. Is that fair to say?
Yep.
I just have another quick question. So the $6 assessment in the materials for the 2017 outreach, there's the $2 million that was spent for the 2016 campaign plus the $1.7 million. So is that the $6, the decreased assessment, that's kind of figured in there? Okay, so it covers it. But you still have to
more customers, less per customer still gets you enough money to do the same program.
Right. But it's the 2016 customers. So 2017, so you won't have that many, right?
No, so you have to be careful about budget year versus plan year versus outreach year.
Yeah, okay.
So we'll be using money generated from 2016 plan year customers to pay for the outreach for the 2017 plan year, which will occur during the 15-17 biennium, if that's not confusing enough.
Right, so it's the 966 times the 2016, you still have the 966.
We have 966, right,
2016
right,
customers.
yes.
Okay, to pay for this campaign for 2017.
Right, the rate filings coming in soon will be for calendar 2017 plan year, and that's when the assessment will drop down to $6.
Good questions. That's the kind of detail I want people to surface, because I guarantee the rest of us were wondering the same thing.
Okay. You're gonna end this process full of all kinds of knowledge that nobody else you know will care about.
It's not good for cocktail parties. Other questions about the assessment, the rebate rule, sort of where the agency, Pat and Barry, are trying to land this big carrier here. So let me ask, we have one more large agenda item. I'm going to target that for about 30 minutes. We have a short presentation, and we'll have some discussion, and then we'll leave some time at the end of the agenda for open discussion and public input. That's an important part of what we do here in Oregon. We're always going to have time for public input. We may or may not have people step forward and take advantage of that, but it'll always be on the agenda. So with that, are people comfortable pushing ahead? Let's keep going. So what we'll do is we'll move to our final agenda item, which is a discussion of basic health plan work group. We'll have a presentation for 10 to 15 minutes. We'll maybe ask some questions, have a little discussion, chart our path forward on basic health plan, and then hopefully on at or before 3:30 we'll get to open discussion in public forum, and then we'll have ourselves out of here well before 4 o'clock. I know that won't make anybody sad to not get all the traffic. Yeah, people, are you headed back today? Yeah, long drive. Okay, Oliver, let's ask Oliver Droppers to come up. So Pat or Barry, can I ask you to do just kind of a 30-second intro? You already covered the fact that the legislature tossed this our way, but just remind us and see if you, without looking, was it 4071 or 4017?
Oh, 4017.
Thank you. 4017 did two things. It tasked DCBS with bringing back to the 2017 legislature a blueprint for implementation of the basic health plan, which is a defined term under federal law that is designed to provide, and I'm sure Oliver will go into some more detail, but it's designed to provide Medicaid-like benefits for those who are whose incomes are just above the threshold of qualifying for Medicaid. Tasks us with having an advisory committee for that process, and then the other thing it does is it basically consolidates other 1332 waiver discussions here, so that we were a little bit afraid, and others were, that there were many good ideas about potential 1332 waivers, and having proponents of those ideas each off sort of as independent contractors, getting legislators to do bills to say do this waiver and do that waiver, and have a single conversation here about what waivers make sense to pursue, which is particularly important given the guidance that CMS provided about what kinds of things they will entertain waivers about and what they won't entertain waivers about. So it's those two elements, and Oliver's here particularly to talk about the basic health plan element of that.
One quick question. 1332 is within the basic health plan discussion, is that?
Well, I think doing the basic health plan would be a type of 1332 waiver.
Okay.
1331, excuse me. So it's a similar type of waiver. The 1332s are a wide array of waivers of the requirements of the basic health plan. So, for instance, Vermont is talking about submitting a waiver that would waive the requirement to have a shop. People talk particularly about something called the family glitch, where that would be a topic for could conceivably be a topic, and we should probably defer some of that discussion to another time. But that's the stuff that would be captured under that.
So for those of you, and I apologize if this is redundant, I'll embarrass myself. I'm not shy about it. Section 1331, Section 1332, those are just provisions of the Federal Affordable Care Act. They allow states to apply for waivers, different kinds of waivers, as Pat outlined. Remember, this is a political process, so one of the things that happened, they passed the Affordable Care Act, and they said, here's the new law, but if you want to make any changes at the state level, here's all these opportunities for waivers. Now, this one wasn't necessarily to satisfy a specific state or group of states, but it was something, hopefully Oliver will tell us, that came from sister state of Washington. It's from an idea up there, and I think it was Congress's way of saying, here's the QHP marketplace infrastructure we're setting up, but if anybody wants to do this separate thing, here's how you would ask us for permission to do that. So Oliver, let me ask you to introduce yourself, start ground level and work up from there. Some people here may be very unfamiliar with PHP, what that means. So don't assume anything and start at the beginning, and we'll pepper you with questions.
Great, thanks, Dan. So Oliver Droppers, I work for the Oregon Health Authority in the Division of Health Policy and Analytics. As some of you may or may not know, there's been a fairly long history of the discussion of the basic health plan. here in Oregon, and as Dan shared, the actual 1331 provision was from our sister state, the state of Washington, from Senator Cantwell. Put that in there because prior to the ACA, the state of Washington had a program called the Basic Health Plan, where they covered individuals that were not eligible for Medicaid in terms of income eligibility at a higher threshold, up to potentially 200%. And so this 1331 section got put in the ACA provision as it was moving through Congress. And ultimately what the BHP is it allows states to create a separate program for individuals that are eligible for APTC, for the marketplace tax credits and premium assistance, from 138% of FPL, which is where the Medicaid income threshold stops, up to 200%. So we know that APTC goes up to 400% in the marketplace. This is up to 200%. And so you could basically, a state has the option to create what they're called standard health plans and to contract with carriers to create those standard health plans and to issue coverage for those individuals. And you can also, the other population that's important to take into consideration when you're talking about a BHP are those that are lawfully present here in the U.S., but they're barred from Medicaid because they've been here for less than 5 years. So there's a sizable population in Oregon for that.
This is great. Let me slow you down just again as we get started here. I want to make sure that we're not losing anybody. Me. So what we're talking about is people from 138 to 200. They are in the exchange, but for reasons that maybe you can elaborate on, the exchange may not be a viable option. And we probably won't get into specific numbers today, but in the future, maybe we can look at, for example, that last group you mentioned of people who are lawful citizens, but less than 5 years, not eligible for the exchange. At some point, they are.
For Medicaid.
For Medicaid, I apologize.
5 years.
I apologize, yes. You know, what's that population here? This is a solution potentially for them. For people who are 138 to 200, can get on the exchange but have found that cost sharing, as we were referencing earlier, may be too burdensome. So I want to just make sure people are grounded on what population we're talking about as we go forward. So thank you.
Could you also give us a sense of what the actual salary range of someone between 138 and 200% of the federal poverty line is, if you know that off the top of the head?
I want to say for an individual, and I'm going to look to my colleague back here, it's about, what is it, about 15,000 at 138?
6,500 for 138, it's about 24 for a single filer for 138 college. That's our program requirements for premium assistance program.
Thank you, Sean.
Thanks.
So that's those are the individuals that we're talking about that would be eligible for basic health program here in Oregon. I think for a little bit of additional context, 2 states have taken up the BHP. So there is some history and some experience that we can turn to in terms of informing the discussions here in Oregon from this advisory committee. Minnesota is the one state. They had already covered individuals above the Medicaid threshold, so up to, I think it was about 200%. So the BHP for that state was an opportunity to free up state funding, general funds that they were already using to cover those individuals in Medicaid and create a BHP, and then therefore to free up those state dollars. So I think that was really to understand why that state went forward with that. New York, similar situation. They also had pre-ACA were covering this similar population in terms of income eligibility up to 200%. Pre-ACA, and so they were able to go forward with the BHP, free up a considerable amount, we're talking about I think hundreds of millions of dollars in this case, and move those individuals into a basic health plan and get that federal funding. So coming back to what a BHP, what it essentially does is the state then will get 95% of the funding that will go to the marketplace for the QHP enrollees through a BHP. So you don't get the 100%. You get 95%. I'm not sure where that 95% threshold came from, but that's how Congress said it. So if a state that goes forward with the BHP, then they get 95% of those dollars that the feds will pay a state to set up the marketplace. So it's a little bit less, and that has a magnitude effect of that 5%. So something I know that this advisory committee will look at.
And is there a duration for receiving that federal funding? Does it end after 3 years?
No, it does. There is no limitation on that. So it's you have to submit a blueprint, as I'm sure that was in the background, and this committee will look at this. Once a CMS approves that blueprint, then you have to submit it and update it annually, but then you continue to receive federal funding for that.
So Oliver, the state share, and if I'm jumping ahead, I apologize. The state share would be that 5% gap plus the administrative costs.
So the administrative costs, that's correct. And the 5% gap is, I think, one of the big questions on the table is whether or not that federal funding would be sufficient to cover all the total costs. And so largely, let me kind of move into the system design parameters. I think we'll get there. But the Wakely study that was done in 2014 indicated that it would be unlikely that the federal funding would be sufficient, so the state would then have to come up because that 95% was not fully adequate to fund the entire program. There we go. So let me go quickly on the timeline, I think, Dan, and we'll get into some of the more, I think, technical questions. So just quickly, back in August of 2013, that's when the conversations in our state really initiated. There was, remember, over at the Portland State Office building, there was some legislators, some OHA leadership, and some advocates really wanting to start talking about what could a BHP be in terms of a policy option in Oregon, and what would be the opportunities. The Medicaid Advisory Committee, which I staff here in Oregon, looked at the basic health program pretty extensively, and we actually did some actuarial modeling to look at what that price tag would be as part of a larger set of policy explorations around churn. We knew that the ACA created this new coverage paradigm. So you expand in Medicaid, you have the marketplace. So we were forecasting that we'd have some level of transition between Medicaid and the marketplace in Oregon. So how do you mitigate those coverage transitions? So and how do you reduce the number of individuals that move back and forth? Because we do know there's lots of data out there that between 100 and 200% of the FPA, it's high income volatility. So you have people that transition 2 to 3 times a year, a significant amount. So the committee looked at that, ultimately did not move forward with BHP as one of the recommendations. There was just too many things going on at that time in 2014 to cover Oregon, and so the committee focused their attention on some other aspects. In 2014, we have House Bill 4109, which is the BHP study. So if you look, that's the large Wakely urban study that I think is summarized in the meeting materials that you all received in advance of this. And then that study was submitted to the legislature at the end of 2014. Legislature took a look at it and directed OHA to move forward and create a stakeholder advisory group. And that was House Bill 2934, and that's where I want to focus my comments on today. Really, is where that group ended up in terms of the recommendations, because their recommendations is I think largely set the guidelines or parameters for House Bill 4771 or 4017. I should know. All right, so here was the process. We met for a series of months. Some of the folks that participate in the stakeholder process are here today, which is great. So if I'm missing any really thing important, please feel free to fill in any critical blanks. But really what this group was tasked with was to look at some of what I would say are the elements of the federal blueprint. So again, the blueprint is what a state needs to pull together, submit to the feds and saying, yep, this is where we want to go, and we as a state will meet the requirements in terms of out-of-pocket, level of benefit coverage, ensuring that there's a choice of options for consumers if you create a BHP, and then CMS will or will not endorse and give the authority for a state to do that. So we looked at delivery systems. We looked at how do you operationalize this, knowing that Cover Oregon was in flux and transitioning, and now we have DCS and the health insurance marketplace. Looked at cost sharing in terms of out-of-pockets, making this more affordable, getting at that issue. So a variety of aspects around how do you design a BHP really were explored, and then we also look back to the results of House Bill 4109 and that actual BHP study. Recognizing, I want to put that out on the table, very important, is that that study was done in 2013, 2014, and some of the assumptions have changed, and that financial data is out of place, out of date. So I think it's really important that the Wakely group is being is redoing my understanding that, coming up with some more relevant numbers, knowing now that the system has stabilized a little bit in terms of the marketplace. So the group, before they jumped ahead and thinking about how to design, I think what they decided to do was to come up with a set of principles to help in that decision-making process. So let me walk through these principles quickly. One was, if you're going to design a BHP, what are you trying to achieve? And so what this stakeholder group advised was, really wanted to increase access for the remaining uninsured. We know we've done a fantastic job in expanding Medicaid, 430,000 newly covered individuals as a result of expansion. Marketplace is doing very well, but we still know that there are some remaining uninsured in Oregon. So is this an option to really get at some of those remaining uninsured, whether because its premiums are still too costly for individuals between that 138 to 200%, whether there's some individuals that are here legally but are barred from Medicaid because they have not been here longer than 5 years. And then at the time, I will say we were also looking at this for Oregon's COFA population. This was pre-House Bill 4071, which I think now has changed that a little bit because that issue has now been addressed, fortunately, in the last session. So one of the other key principles is how do you increase affordability for low-income Oregonians? Again, the 138 to 200%. And then how do we reduce churn? Because if you think about one of the issues that this group looked at, OHP is some would say a fairly rich set of benefits, and so and out of pocket is nominal for folks that are on OHP. So if you make just a little bit more amount of money, you go from 138 to 150% of the poverty level. You now have to pay out of pocket for certain premiums and out of pocket costs, as well as you may have less benefits in certain categories. So they wanted to understand what that was. So I think BHP, depending on how you want to structure the benefit coverage, if you want to offer the essential health benefits on the marketplace or offer more richer benefits such as what's offered in Medicaid for adults, thinking about that. And then another principle was an accountable care model using a measurement framework to really incentivize quality and population health improvement. So thinking about what we've done with our CCOs in Oregon and really pushing that envelope and using BHP to help expand the coordinated care model is I think one of the other key considerations. There's a few other ones. Sustainable and predictable rate of growth. We've been doing that in Medicaid through our 1115 demonstration waiver and our CCOs. I've been doing a fantastic job at meeting that 3.4% growth rate. So if you're going to design and put forward a BHP and try to make it as cost neutral to the legislature, thinking about is there a way to cap that rate of growth using BHP. Maintain a healthy and vital marketplace. I think there was clear recognition among this stakeholder group last year that they would not want to put forward a BHP that created any disruption in the marketplace. So that's something that was critical. And then lastly, ensuring that exercise stewardship of state resources by maximizing federal resources available through the ACA. So thinking about the 1331, the BHP, and also possibly how could you maybe or maybe not leverage 1332 to go from the 95% federal reimbursement all the way up to 100%. So that was where the design principles, I think these set of principles were really helpful for the stakeholder group to move forward. So here is the framework that they ultimately landed on, and it was termed hybrid marketplace. I'm not sure terminology, I think was least helpful. What they put forward as a suggestion in the report that was submitted to the legislature was creating a BHP but using CCOs and commercial qualified health plans. So allowing CCOs and commercial carriers that currently offer health plans on the marketplace to compete for this set of covered lives, and then using the coordinated care model as a requirement for being able to issue a BHP health plan on the marketplace. So let me stop and see if there's questions about trying to, I think align Medicaid and what's going on in the marketplace was really, I think, the core principle here.
I have a question, Oliver. You mentioned a few minutes ago that the Medicaid benefit is pretty rich, and I think we all know that. There's a discussion around a less rich benefit, similar to the metal tiers in the exchange.
Yeah, so Dan, that's a great question. And I think they struggled a little bit with that discussion. I think where the consensus to some degree was this was an opportunity to have individuals that are still viewed as being low income and to give them the full Medicaid set of benefits. I don't think there was unanimous agreement among everyone on the stakeholder group about that. I think some said we need to look at that cost implication and really think about and keep looking at the 10 AHPs versus full Medicaid. The one where I think you see that played out most is in they decided not to also include adult dental because of the price tag. So Medicaid benefits except dental, and the rationale was adults currently on the marketplace, dental is not included. That's a standalone benefit. So I think that was probably one of the most contentious issues.
And it is, dental is available on Medicaid. And so, you know, a middle ground might have been to offer a less rich medical benefit at a dental benefit in. And I'm not taking positions, I'm just trying to point out some of the trade-offs. And as we get to some next steps here, we're going to ask some of you to participate, just to give you a preview. We're going to ask some of you to participate in a work group going forward. And these are the issues that you're going to have to wrestle with. They've been on the table for several years now, but as you mentioned, even within that work group, there's differences.
And I want to say the other important part of that kind of decision-making process that played out with the stakeholder group is House Bill 2934 that directed this was very specific in saying, look at that prior 2014 study. So we didn't have updated information in terms of, that study looked at Medicaid in terms of cost and looked at what was available in the marketplace. And we couldn't look at any other midpoint in permutations of benefit coverage. With the available information, this is where the group landed. I think we did have some discussion. I recall they would like to have more, be able to kind of run the numbers again in terms of the overall cost around changing the benefit structure, but there was no funding to support any additional actuarial models. So that's...
And there is, and this bill did provide funding for delivery run. That's part of what.
In fact, today the contract is going out.
Wait. Okay, good. So Oliver, let me ask you just to kind of move through the rest of these, and then we'll have some questions. I know you'll get several questions coming.
Great. So this is overall, I won't go into much more detail. I just say the provider reimbursement, they picked the midpoint, not Medicaid and not commercial, so they chose approximately 81%, which is kind of the Medicare reimbursement rate. Premium, so more affordable, so graduated cost sharing above 138. No deductibles or copays. Marketplace standards determine eligibility enrollment. Consumers have to have a choice, and then the annualized growth rate. Didn't specify the growth rate. Let me be clear on that. What they said, we need to have some kind of annualized sustainable rate of growth. Doesn't have to be the Medicaid 3.4%.
Oliver, I think that's a typo up there because that's just the average of Medicare and commercial. At 81%.
Yeah, you're right. Thank you, Dan. So it's 81% Oregon's commercial Medicare reimbursement rate. Yeah. Thank you for that catch. I'll correct
just
that.
Channeling Jim. Thinking about, you know, quality imperative and driving people towards higher quality plans where we know the state's getting more for its dollar and members are getting better health outcomes, hopefully. I didn't see that in that list there, but maybe that's something that there's room to add to the discussion. I don't know, Jim.
Once we have metrics, because there is where we're going to be polling or asking participants what their experience has been, but yeah, that.
So I think the group, how they were trying to get at that particular question, Dan, was really thinking about the coordinated care model and saying we have really strong metrics in CCOs. So how can we take a similar set of metrics and apply that over maybe some kind of incentives, set that aside, but use those types of metrics to really drive the quality. And I'm not here to say whether or not that's applicable. You can do that. So I don't want to, I know we're short on time, but I just want to say there's a whole host, a list of advantages that this group came up with. It should be in your meeting packet. If not, I'll make sure to share it with Barry, that you get that. But they really saw a lot of opportunities, I think some of which we've already discussed, and they're kind of also reflected in some of their principles. Picture, oh, there we go. And then a couple of potential disadvantages to Dan's earlier question about federal funding may not cover the cost of a BHP in Oregon. That's a really important one, and I know that's something that the legislature really was very direct with the stakeholder group. Representative Greenlick was there on the first day of this, when the stakeholder group was convened, and said, please find a way to make this pencil out. So I think that's probably carries over in terms of where the legislature would like to see some of this work. And then state funding for the startup and ongoing administrative costs as well. And then lastly, which is the big question, this group don't have the information, is the uncertainty. The Wakely and Urban Institute 2014 analysis touched upon this to some extent, but because things have changed, I think we can't really look to their conclusion, and that's really about whether or not this would destabilize or help further stabilize the marketplace and creating and separating the risk pools. If you took BHP, you could, my understanding is that it would create a whole other separate risk pool than what the marketplace, so you'd have multiple risk pools right now in the marketplace.
Dan, Oliver, they're going to take a look at that point again too. Right.
One of the things we have, Oliver, thank you, that was a great presentation. One of the things we have since the last Wakely report is we have another couple of years of experience. And we all know what happened in Oregon in 2015 with a couple of important market players. So that adds another layer of analysis for them to say, how would BHP have changed the health of the public or the voter experience, or the losses that have been widely reported from even the health plans that stay in. I will just mention Ken Preventure. He's not here. I did talk to him ahead of time, and he in particular is very concerned about market stability in the marketplace. And I know we all will be focused on that, but I think at the next meeting, if Ken's able to join us, that's something you can expect to hear from him about carriers coming and going from the marketplace itself. And would BHP exacerbate that or promote that? Don't know. So it's time for questions.
So I understand there have been some other states that looked at BHP and stepped away. And are you familiar with that? And can you?
Please do. So my colleague here, who's worked extensively with the BHP.
We're buddies from two agencies.
So I think to your question, Jim, I don't know, Deanna, if you want to actually touch upon that. The other states that actually looked at it and then decided not to move forward with it.
Part of what we're...
Dan, why don't you go ahead and introduce yourself?
Oh, I'm sorry. Yeah, Jim and I actually met back in Cover Oregon days, but the rest of you, I'm Deanne Gilmore, and I work in a policy and data kind of role here at the marketplace. The part of the expectation of what DCBS will bring back is to address and discuss and respond to each of the kind of recommendations that came through from the stakeholder work group, but also to do the kind of look around the country and see what's happened in New York and Minnesota, but also take a look at what the considerations were of the states that chose not to. And for example, Washington no longer has a BHP, and learn a little bit more why that's the case. And so to really try to lay out all the big picture of public policy about all of this.
Do we know, Deanne, Oliver, the program has an objective, and there may be other ways to reach that objective, and have other states like Washington or other states that have declined, or even the states like Minnesota and New York that have sustained a BHP, do we know what other alternatives they looked at and pros, cons? Is that in the scope of the Wakely report, or is that something that you folks will bring to us?
It'll be part of what we'll be looking at, and also Wakely will be helpful in that. And we do know that both Minnesota and New York had looked at 1332, then some uncertainties came in. I don't know where they are right now with 1332. That'll be part of what we'll be trying to find out as an option to try to get at. Something Oliver and I've talked a lot about, and others, is are there ways to advance some of the goals and aims of a BHP, but do it through 1332 or other means. So Oliver?
No, I mean, I think it'd be great to look at some of the other states and what was that decision-making process that led them not to go forward with the BHP.
Yeah, which may or may not relate to us.
Sure. Yeah, just look up. Is there a plan for, or at least with similar programs that exist already, you have to apply for emergency benefits through the Oregon Health Plan prior to getting onto a marketplace plan? Do you have a plan for expediting that process? Because that tends to be the biggest hang-up in getting clients onto that, because there's no structured outreach and information available in multiple languages, and this tends to be an immigrant population that doesn't speak English or just got to the United States and doesn't understand our health insurance system whatsoever. Do you have a plan for the support for getting those letters from Oregon Health Plan, or is that going to even be required before applying for a BHP specifically?
So I think that's a really good question. I think that's kind of gets really far into the implementation questions, and that's something that we didn't get to that point in terms of how that would actually play out. But I think recognizing that is the reality that would have to be if the state were to pursue and go forward with that.
But that is coming up during the COPA implementation, so it's a great question, and we are kind of struggling with that, and we've already started working with the Oregon Health Authority to figure out, is there a way to expedite that denial process so the person can get coverage that much more quickly? So, yeah, it's a great question. Would you like to be on the?
Yeah, hold that thought. We're going to nominate
Yeah.
Sean. We're not even going to give Sean a choice.
Are you referring to the population with the 5-year waiting period?
Yes, any case when you're trying to get onto a qualified health plan, when you would ordinarily be qualified for Medicaid based on your income, you have to get a denial from the Oregon Health Authority first, and then that is what qualifies you for the getting onto the
So there's a
marketplace.
significant change in the health insurance and on healthcare.gov.
There
It
is.
automatically determines that. I just had a client that
There's
switched
a
from a QHP to what would be OHP. It's dual eligibility, so one person over the 5-year, one under the 5-year, and the eligibility printed out. You get Callum and tax credits, and husband gets just OHP. It was tremendous.
Okay, so they have
yeah,
box
just last week.
late.
Yeah.
Okay, great. Well, that's good.
Yeah. Sorry.
Well, that's good. Learning. Maria, did you have an additional point?
No, just that there is a workaround for that they've established for that population.
We got one late into the process last open enrollment, but it was just something that was continually until then. But so I just want to make sure that was addressed as well.
Okay, I'm going to tee up Barry in just a minute, but before we ask her to walk us through next steps on BHP, while we have our experts here, I want to see this is a chance to ask questions about BHP. We ran through a lot of content. There's a lot of history here. People have been working on this for years, so some of us will have time to really dive into this, but it's important because we're going to be asked to provide a recommendation, and there's a lot of work between here and there, but I want to make sure even those of you who are not on the subgroup are comfortable enough with our next step. So any questions about BHP, any questions about why we're talking about it, why the legislature gave it to us? Cindy.
I just have an observation. I know everybody here knows a whole lot more about this than I do, but it kind of brings up one of the concerns that I mentioned earlier in the introductions is I'm worried about the data, the age of data, and just kind of moving forward. When things have changed pretty remarkably in the last 2 years, and how do those changes, you got to do some movement, but if it's bad data, the result can be pretty.
What in particular, around income or enrollment?
Well, income or the churn, the churn that happened that you were looking at in 2013, 2014, how is that affected now after, what are we, 2.5 years into the Affordable Care Act implementation? And, what's the churn like in other market, other parts of the individual market? Those are the things that I'm just concerned about.
I wonder the update, for example, that Wakely's doing, and also any analysis that we will do as staff will benefit from everything that's happened in the last couple of years, to the most recent data that you can get is.
Dan, you've touched on it a couple of times, but could you take just a minute and talk about the scope of what exactly it is we're asking Wakely to do in this work that we just commissioned?
Yeah, Wakely's supposed to go through and take every one of the kinds of assumptions that, we'll treat them as assumptions, every one of the recommendations that were made by the stakeholder work group. So for example, to have a Medicaid OHP plus kind of benefit package and price that out with both dental and not dental. Take a look at what it would be with, with the average of the Medicare and the commercial rate. So, every one of the kinds of recommendations about what would a basic health program look like there to do that. But they're also going to help us take a look at what would be the effect of putting this kind of program in place. And part of what actuaries do is a combination of statistics and math and really making assumptions and projections. And for that, they will look at both what's happened in Oregon, but also turn for some of their assumptions to what's happened nationally. And they really do make their assumptions pretty clear, describing what it is that they're doing. And so they're going to help us take a look at what the impact might be on the risk pool, and churning, for example. And when they did the 2014 report, they actually identified that the biggest churning took place between the individual and small group market, not between the individual and Medicaid. They did acknowledge that there was some churning there, but that wasn't where the bulk of the churning was. Now we've had 2 years of experience.
Right.
So let's see where that stands. So at that time they were projecting pre-ACA what the reality might be. Now we're going to have a couple of years, and so having that kind of information is going to be really helpful. And so first of all, the subcommittee will get a report back, and we'll be able to say, well, what about this and what about that? And we can then ask Wakely to recalculate some things that's within the scope of work before it ever comes, to the full advisory committee. So there will be a full report there, as well as the kind of staff work that we can do by going and talking to and looking at what's happening in other states. Earlier, there was a comment about the 95%. One of the things that makes it challenging financially is that it's actually less than 95%, because the assumption is that you will be providing a much more substantial subsidy than what someone would get in a QHP. That's part of the point of doing it. And Oliver, did you want to mention about the IT issue? Because this is another kind of practical implementation.
Yeah, sure. Thanks, Dan.
I'm tired of me talking. You talk.
That's the other thing, is because we do use the federal platform for our marketplace. We did have conversations with CMS last year about this, and they cannot do customizations to our marketplace. So if Oregon were to pursue a BHP, they said for the next few years they cannot customize the FFM with the eligibility and rules that would be needed to plug in a BHP at the FFM. So that's a big consideration for this group as well. So there is an IT factor there.
Another reason to get creative and think about ways to approach these same problem solving in different ways. So
correct me if I'm wrong about this, but certainly if we had a technology platform that could be customized with those eligibility rules, that would make this all vastly easier, but it wouldn't actually be impossible to implement a program like this while we were still using healthcare.gov. We would just have to have a series of workarounds, and maybe some of the application process would have to be on paper and so forth.
Hope on a much bigger scale.
Right. But so there's a trade-off there, is what I'm saying. We're not necessarily precluded from doing this if we choose to stick with
we're not precluded from thinking of greater subsidy approaches.
So last questions or comments, then I'm going to turn it over to Barry, but again, don't want to cut off people. Have any questions about the remarks?
I just wanted to make sure, as the application process balloons and gets between more different programs and all of that, that becomes progressively harder for the client to do at home, which is essential to saving money, because then you're not putting, every time they come in for casework with a social service agency or government group, you're creating follow-on expenses. The more we can simplify this down, it's really going to be about getting people onto the program so we have large enough risk pools, but getting that ease of access and having at least a website where everyone can get the process spelled out for them, so they are able to do it at the home if they're reasonably healthcare literate already and all of the other requirements. But that really just needs to be impressed on that sign-up procedure.
So administrative simplicity from the consumer perspective.
Correct.
Yeah, gotcha.
Streamlined, how it was originally intended.
I do have one question.
Yeah.
So it sounds like a big piece of this too is that this could potentially free up state funds for other things. Would the Wakely report address that at all?
So I don't know if this would free up state funds, because
would be my only, my biggest.
Great question, Shannon. So we did look at pregnancy-related coverage between 138 and 185, because that's currently in Medicaid. You could potentially move that into BHP and free up some state funds. I'm going to look to Mark as well here as being OHA. I think we want to be very careful of talking about starting to peel off Medicaid eligible individuals just to free up state funds. And I think if you have that conversation at the federal level, they're going to really be reluctant if that's your rationale for BHP. So I just want to put that out there.
Callum more, so I mean, not 100% Medicaid, but the Callum eligible individuals, and I guess I feel like that might play into it, but.
Well, they probably wouldn't be eligible for this.
But they're, no, in the 5-year residency, they would. In the 5-year residency, you get Callum and tax credits, you're dual eligible, so those people wouldn't be receiving Callum anymore because they'd be under the BHP.
I guess it depends on the eligibility, because if the BHP follows marketplace rules, like for not legally present.
No, so within the 5-year residency ban, only that are on Callum and a QHP, so that clientele base wouldn't be on Callum anymore because the BHP would pick up that. It sounds like that's a big population that you'd be addressing, is people in the 5-year residency bar that aren't eligible for full Medicaid, but income-wise would qualify, right?
Yeah, we have some numbers to that, so I don't know if the committee at some point wants that, we can bring what those numbers would be to help inform the conversation.
Excellent.
Wouldn't they still be on Callum though? They'd be using the benefits less often, presumably able to bill more to the basic health plan rather than the Callum benefits when they have an emergency, but they'd still be enrolled in that. That's
I don't know. I mean, I guess my thought would be
Would it be
no.
replacing that? Because currently you have a qualified health plan with Callum as your secondary coverage.
Right.
Perhaps this is a good opportunity to transition to who's interested in being on the subject.
Well, that's
So-
what I was going to say. I think that really what you're getting to is a level of analysis that the worker is going to have to do. This is going to be very data driven, and it's going to have to tease these things out. We do have, happily, data and lots of great counterpower to push this, but that worker is going to have to take these issues and think about, so if we get it designed like this, what happens?
Right.
But I think you're right. Oliver's right. Be careful about teasing out more state dollars. It's going to be a challenge.
So this was really part of our evil plan. We just had these people self-nominate themselves to the work group because we have these incredible subject matter experts who are working with these clients, and this is exactly the expertise we need, because I certainly don't have it, and there's probably a number of others who are like, I have no idea. So Barry, next steps, and then Sean and Shannon and Maria and others, maybe get ready to raise your hand when Barry says, when Barry lets you know when it's time to raise it.
So perfect. So as Deanne mentioned, we engaged Wakely and hope to have the results of that by I think late May, right?
Yeah.
Hope so. And so that'll also be the time in which it'll make sense to have the first subgroup meeting for BHP, and then of course also begin the 1332 conversations. And so there's a lot of folks who've been engaged on this issue over the last few months who will be natural fits for that work group. But I think probably a great way for continuity of conversation would be to have some folks from this group also be on that work group. And that way when we come back and present recommendations or reports and updates, there's a group of folks here who are really committed to that conversation. So glad to take volunteers now, glad to take volunteers later. And also just, is this committee supportive of that idea of how to structure that feedback loop between the work group and the full advisory committee?
And what would that work group look like or entail, the meeting structure?
I always want to be realistic when I tell people because I don't want to ever underestimate. And so ideally, probably you'd be looking at least one meeting a month of at least, 4 hours in length. And this is the BHP report is due to the legislature in December of 16, and the 1332 report is due in March of 16. So it's really, and I think people could probably be on both. They could be on one or the other because at times they're the same conversation, at times they're separate conversations. So.
So let's start with the BHP. That's sooner, and I think that's pretty critical to us. Is there anybody here, and I would like to get some names here. I appreciate that you do some follow-up, but I'm really hoping some of you with the subject matter expertise would be willing to provide that link between this group and between us, because we actually have to make that final recommendation, and I think it's imperative that we have some folks around this table involved.
Can I just clarify also that the intent is to invite a bunch of other people into this work group as well. It's not just a subgroup of us.
Yeah, and again, this is, to me, is sort of the model going forward of the ideal structure for this group to do its work is, to the extent we get into really in-depth things, largely bring in other folks who are subject matter experts, but with some folks around this table who share that expertise so that we've got some cross-connection and can bring good conversations here. it really is a way of expanding your scope beyond just the 13 people around the table.
And also would say that I think it's important, certainly, I don't know about my colleague Pat, but there's a large body of work, as you all are engaged in day jobs. And so, especially for me, I got to be able to, if I'm going to commit, I'm going to commit. I'm going to be there. So in the subcommittee, I mean, this group I'm in, it starts to pile on to think I can go to I'm going to miss it. I am. I can tell you right now, the tyranny of the urgent is going to pull me out into other things. But I can think about who on the finance team that I have would be appropriate. And there are policy and analytics. I mean, within the organization, there are some folks who are, they're a lot smarter than me. And I would be happy to locate somebody, perhaps somebody from the actuarial services unit who builds rates for the Medicaid program, top to bottom, and works with our actuary very closely. That might be somebody who's very terrific on that subcommittee.
Yeah, so
I'm happy to do that. Does that make sense?
That's a great follow-up with Barry. Thank you, Mark. And in terms of people here, Shannon and Sean, not to put you on.
No, I would love to.
Terrific.
Yeah.
Shauna, Shannon, and Sean.
Oh my, love it.
That's great. And there may be some phone access. There may be.
Oh, absolutely.
There's some probably a little more flexibility.
We don't do anything without a phone call option anymore, so absolutely.
And just a final point, Maria, that doesn't preclude you from joining. And we're having some offline conversations with your colleagues here, with Barry.
Thank you.
Just because I understand you want to commit. That's a big commitment for somebody out of town. So.
And each of those meetings will also be public meetings that will have a public comment period. So, if at any point during that conversation anyone from here wants to go in and make a comment, that will be an option as well.
So Barry, just to close this out, the next thing we'll hear from you on the BHP subgroup is what?
We will send you the actual kind of specific timeline for the work plan and what to expect in terms of timing, and then some idea about dates for meetings.
Thank you so much. Okay, we are at the end of our agenda. We want to leave time for open discussion. Items that were on the agenda, we'll start with Joe. And then if there are folks in the audience who want to say some words to us, we're open for that as well. Joe.
Piqued my interest when you said you were going to send out the timeline. Is that for all of us or just for those who volunteered for that subcommittee?
So I will send that out to all of you, just as in terms of kind of follow-up materials, but then we'll get more detailed actual dates to the people who volunteered to go to the subcommittee. Yeah. Please, go ahead.
In the handout, there's kind of there's a draft, very large timeline right now you could refer to. I think you're talking about a more detailed timeline, but if you didn't notice that, that might be helpful.
Any public comment? I know some people have hung in there with us for several hours now.
Can I have a process question first?
Yes.
We haven't talked about the 1332 waiver piece of this as much, and I know that's a huge topic. We can talk about it at a future meeting, but since that is a related discussion to the basic health plan discussion, I had sort of thought that we had discussed having the same work group sort of work on both of those, but I'm not sure exactly how we want to manage that process. And also for my own part, I am more interested in being involved in the 1332 waiver discussion because I feel like there's a deep bench of people really invested in BHP who can cover that, but I'm actually really interested in 1332, and I'm not sure that there are very many other people who have looked into it in Oregon, so I want to be part of that discussion. So I want to make sure that everybody here knows how to interface with those two separate but related discussions.
This is how we've kind of looked at it, but I'm certainly open to other recommendations. Is that we're really going to start with BHP because of the more urgent timelines for the recommendation and build out that work group. And also, it's really the discussion really centers around that early data that Wakely will bring back, and then we'll kind of move from BHP to 1332. And then some of the same people who are interested in BHP might also want to stay on for 1332, but that will be communicating with this group and other stakeholders, frankly, who want to participate all along the way. So we'll be kind of dropping off and the new folks will be joining. So it's a little bit seamless, but also a little bit sectionalized, if that makes sense. And just from a communications standpoint, one of the things that I think I mentioned to somebody on the phone is that there's all this info, there's the weekly updates going on, there's subgroups going on, and so that weekly email I send out to you is meant to be kind of a grounding and here's what you need to know about the marketplace this week to the extent that you want to interact with the things going on. And so I'll try to always provide, next week is the COFA Advisory Committee if you want to pop in, next week is BHP, or next week we're going to start talking about 1332 if you want to engage, and try to give you lots of notice about dates, but that'll be a way of kind of keeping track of what's going on.
Got some great staff here, Barry. Thank you.
We really do.
I meant you.
You, yeah. I know, that's what I'm saying. I'm really bad.
I wasn't referring to Pat.
No.
No, we appreciate, this is a great, we appreciate all the prep work that went into getting us to this point. You guys are really putting us in a position to succeed. Appreciate the overview, the analysis, setting us up here to move our work forward. Let me close by asking, people have anything, there were some materials that we didn't get to, but they're in your materials around the small business survey, some things that we'll put on the next agenda for May. Other issues either now or in the coming days, if you think about it, ping Barry and let her know and we'll get that on the agenda. We need you to drive the agenda. We will bring you a full agenda, but we also need you to tell us what it is we should be focusing on and hearing about, and learning about, and advising on. Is that fair?
Absolutely. Yeah.
Yes, so with that, we'll close. Did I see anybody in the public raise their hand? Welcome to step forward. We have a brief amount of time. We'd love to hear from you.
Hi, good afternoon. My name is Janet Bauer. I'm a policy analyst at the Oregon Center for Public Policy, and it's been wonderful to listen to your opening discussions today. Our organization has been, supportive of considering the option in the Affordable Care Act, a basic health program, that could potentially address affordability issues that Oregonians currently face. And so we've been participating and following the discussions in previous work groups and really look forward to seeing things continue to move forward. One thing that I would say that has been very helpful in previous work groups is that we've had broad stakeholder participation. Many industry players have come to the table, consumers, and have brought, I think, put concerns and issues on the table, and that environment has allowed some creative thinking. And so if I would say anything, I would say it would be really great to have a similar broad stakeholder group wrestling with some of these big questions, getting some of the best minds, because in the end we want to have a product that is well vetted, that is well understood by industry stakeholders, and so we have as much clarity as possible going into the next legislature. So I just want to thank you for your work and look forward to hearing how things go.
Thank you for getting us to this point. Janet, I know there's a lot of work in Jonathan over the years. So, John?
Thank you, Dan. John Mullen from the Oregon Law Center. Happy to be here today. For those of you not familiar with the Oregon Law Center, our mission is to work on achieving justice for Oregon's low-income communities. In that context, a couple of us started kicking around some ideas back in 2011 when we started to take a look at what the Affordable Care Act had in it. We started talking about basic health. We started informing the legislature about it. Linda Romano is also here in the room, and a ragtag group of advocates, we eventually landed on a name for a coalition. The reason I want to bring that up is because I like to say that our values are right in the name of the coalition. It's the Inclusion, Affordability, Innovation Coalition. And I point that out because I think the way the meeting was framed today, both the way Pat talked about the advisory council function and the way Dan asked you to really bring your expertise, but then also look at the larger picture about where we're trying to get. So I think those anchors as far as values are concerned are really very important. I want to end with also another appreciation, and that is that we had wonderful cooperation and work with Pat and with Barry and Deanne and others in DCBS, and also with Oliver from the Oregon Health Authority. So the advocacy thrust around all of this is not so much that we are looking for a specific outcome, but we're looking to achieve those values that I mentioned.
Thank you both so much.
Thank
Linda, would
you.
you like to say a few words? Come on up. I'd love to hear from you.
Hi, good afternoon. My name is Linda Roman. I work as the Director of Health Policy and Government Relations for the Oregon Health Equity Alliance and the Oregon Latino Health Coalition. And with my colleagues, we share the values of the IAI Coalition, but we also come together with the value of ensuring that all Oregonians can achieve their full health potential. And before I talk about that, I want to thank you all for your willingness to be part of this process and to ask some of those hard questions and to really get responses because our community is really relying on some of your representation. And Maria, you coming all the way from Eastern Oregon. I appreciate the time that you took to be here today. I just also want to talk about how this process for us has been informative in moving us in the direction that includes a diverse range of stakeholders and insights to get us to the point that where we are today. I've appreciated the process that has included community advocates, consumer advocates, insurers, hospital systems to really bring forth their point of view. In addition, it's been also helpful to have the council of lawmakers in this process as well, especially to give us an idea of what do they want to hear from us. Do they want something that doesn't cost any money? Do they want something that's budget neutral? That kind of counsel is really important to us in the stakeholder process, and we hope that it is broad enough where that those insights are also welcomed. So we strongly encourage that kind of process that includes a broad range of stakeholders. I'd also like to thank Pat and Barry for their work on this and the great work of Deanne and Oliver to help inform this process in the way of breaking down what the Wakely study would be like and their work on that. That's all the comment that I have, but thank you all for your time for being here today.
Yeah, Linda, thank you, and for all the work that preceded your remarks today. We know you've been at this for a long time, and we appreciate it. Appreciate it very much. So with that, we'll come to a close unless there are any parting words of wisdom from anybody or thoughts or questions. We'll see everybody, Barry, May 9th.
May 9th in Umatilla.
Now, is that the same weekend as Roundup? I'm assuming you coordinated.
Better not.
Hope not.
Yeah, we're a little early. It's a warm-up Roundup.
Yeah. Don't do that to me, Dan.
Travel safely.
Yes.